Hello, everybody. Greetings from Hospital Puerta de Hierro in Madrid. We are proud to begin this second iCTO meeting. I think we have two very interesting cases, and there's going to be much for discussion. We also have a great panel, and we are proud to say that we also have some colleagues from Portugal, and I think it will be very interesting to see their point of view regarding CTOs. Also, I would like to thank our sponsors, Boston Scientific and World Medica, that made this possible. And nothing else. I don't know if you, Javier, have something to say.
Yes, thank you for connecting. It's a pleasure. It's a pleasure to be with our Portuguese colleagues, and we are eager to know your opinions and to discuss the case that I'm certain will be of great interest for teaching interest. Ignacio.
Thank you very much, Javier, and thank you very much, José Antonio. I want to thank, of course, all the panelists. I want to thank the participation of our colleagues from Portugal as well. We decided to do this kind of meeting first to restart with the CTOs, because we have forgotten these patients, like if it was not important their treatment due to COVID. But now we believe truly that we need to restart treating these patients because the clinical benefit is clear. This is why we performed our first session last week. That is already in YouTube. You can see the whole cases and presentations if you just write iCTO meeting in YouTube. And we will share also the link for the presentations today. Today we will have a multilingual course. We will be discussing in English, Spanish, Portuguese, and whatever language necessary to make us work better. The initiative of working in these sessions with Portugal is driven from the Iberian Registry of CTOs that has been ongoing for about 3 years with many centers in Spain and some centers in Portugal, and more than 1,600 cases recruited by now and several research projects ongoing. So thank you all the participating institutions. Please contact any institution that is not participating now if you are interested into collaborating. And I don't want to extend anymore. I will give the word to Dr. Rumoroso, who is our referee, our moderator today. He will have a tough work to coordinate all of us. So thank you very much, Dr. Rumoroso.
Hello, Nacho, José Antonio, Javier. I'm going to introduce you the panelists that we are going to have today. We will have from Oporto Santo Antonio Hospital, my friend João Silveira. Hello, João. We also have Pedro Cardoso from Lisbon, Hospital de Santa Maria, another good friend of mine. We will also have from Hospital Valdebron, Bernat Serra, and also Antonio Gómez Menchero from Hospital Juan Ramón Jiménez in Huelva. We will have some presentations and some lectures during this morning between all the work that Nacho and José Antonio are going to perform in the patients, all the intervention that they are going to show us. And we will try to connect, as you know, CTOs can be tough, long procedures, so we will connect at every time o'clock to see how it's going on. And we will have time to discuss all the strategies, all the techniques, tips and tricks that we are going to see. So maybe we can start showing the first case, and let's see what we have from Madrid. So can you present the case, please?
Good morning for everybody. I'm going to present our case from Puerta de Hierro. The patient is 81 years old, with hypertension and dyslipemia. Years ago, a dilated cardiomyopathy and atrial fibrillation were diagnosticated. Initially, the ejection fraction was 45%. In coronary angiography, only he has a chronic occlusion of the middle segment of the right coronary artery. Cardiac MRI saw only a small area of necrosis in the inferobasal segment. At follow-up, he developed severe mitral regurgitation. Mitral clip was implanted 3 years ago. Recently, a patient present worsening of ejection fraction despite optimal medical treatment and surgery implantation. Due to the progressive deterioration of the ejection fraction, we decided to treat the CTO. This is the coronarography. The arteries of the left territory don't have significant stenosis. A large epicardial collateral connects the LID with the posterior descending. In the right coronary artery, there is a long CTO in the middle and distal segment that ends at the origin of the PDA. In the CTO, there is a great adventitious circulation with a corkscrew morphology. We have calculated the iCTO score in this CTO of more than 20 millimeters and with evident calcification. In this case, the score is 2. Now, this is difficult. We have also calculated the J-channel score. It is a non-septal collateral. In this case, only the presence of the reserved veins score as negative. The total result of score is 1. This is intermediate, difficult to use the collateral for CTO treatment. Now, I would like to return to the cath lab to discuss possible options.
Okay. So we have a very interesting case with many issues about the clinical history, because it started with myocardial dilated myocardiopathy with 45% of LV function, and now we have 25% of LV function. Just only one question before we discuss something about the approach. What about the mitral regurgitation now? Is already corrected with the mitral clip?
Yes, it's correct.
Can I answer?
Yes.
When we performed the mitral clip about 3 years ago, the patient experienced a huge improvement in his clinical condition, and the mitral regurgitation went down from 3.4 to 1.5 more or less. Now it's increased. It's more, about 2.5, I would say. But it's also together with a significant decrease in LV function. So probably that has an important part in the history of the patient. I don't know if it was mentioned, but I think so. Recently, early this year, the patient has been resynchronized. So we are using all the battery of strategies to handle his left ventricular dysfunction.
Okay, so maybe we will have many things to discuss afterwards, but in terms of the technical strategy to approach this type of CTO, which I think the JCTO score does not reflect the difficulty of this case, clearly, because I think it's much more difficult than maybe 2. What I can see that you have already started. So, what is your plan for this case?
So maybe, Jose Ramon, if you are so kind, we could first discuss what the panelists and yourself would choose. I don't know if, have you seen the videos from the patients that we've taken today?
Yeah, we could see the videos. So no, it's just only because you already started to do something. So, but
yes, we'll discuss. But I'm interested.
I agree. Okay,
so
I agree.
Do you want me to play the videos before, or just briefly, and maybe open a small discussion?
Okay.
Actually, as you can see, we have opted for the retro approach to the epicardial, which carries a plus of risk to the patient. But we could have argued, and some people may argue, for an anterograde approach. Actually, there is a connection. Maybe we can see it. José Ramón, do you agree? We show the...
Okay, yes, please.
Wait a minute.
Por las primeras, si quieren.
Okay, so first of all, we had a significant difficulties. You can see the iliac arteries are very tortuous. You do not see the tortuosity here because actually it has been straightened by the sheaths and the guide. The guide wire, the 0.35 guide wire, is the new guide wire for Masaji that I think is excellent. It's kind of a mixture between a Terumo and a Teflon guide wire. So we have, that was the first difficulty to be gained, and then we can, I'm interested for you to look closely at the right coronary artery. There's actually a connection. It's a corkscrew connection, I would say. Many people would think it's an adventitial connection, but maybe it's also it could be a thrombus that has been lysed. So you could argue for the anterograde, and there's actually a connection to the crux. And what we see there is that the distal right coronary artery is diseased up to the crux. I will look at just to liven up the discussion. You see the same things, I think. I don't know if you're able to see correctly the videos, José Ramón.
Yeah, perfect.
Okay.
The quality is very good.
And you can see here that even from the PDA, I mean the posterior descending artery, you have a connection to the crux which is quite angulated. And you can see that the epicardial connection is large, but very tortuous. So plus and minus, what would be your approach? We have opted for the retro approach, but I think it's an open question, José Ramón. What do you think?
Okay, I will say what I think in the last place, because I would like before to ask some questions to the panel. There are some questions regarding safety. For instance, we have a patient with 25% of LV function and retrograde approach, which was initiated right now. So, Joao, can you hear me?
Tienes la búsqueda, si quieres.
I don't know if Joao has any problem.
Do you hear me, Jose?
Yeah, Joao.
Okay.
What's your opinion about the case?
Okay. But getting back, my first question is indication of the recanalize this RCA. I have some doubts about indication. This is the, as you know, Emmanuel Bilakis published last year the 7 point of the consensus of CTO. The most important is to improve the symptoms. I am not sure if this is the ischemic cardiomyopathy. This is the first point. I don't know if the mitral regurgitation is not functional more than ischemic, or probably ischemic and functional. This is the point, one point. Regarding the procedure, we have 3 possibilities. When you are talking about hybrid approach, you can, the safety is the main issue that you will keep in mind. For me, the safety, efficiency, and efficacy. And you are talking about the safety. The safety way to do this CTO is to do directly to retrograde. You have a very, very good interventional collateral from epicardial collateral. We don't have any septal collateral for this mid RCA, but when you use the SUA, when the Caravel, I think it's the safe way to do this CTO. Also, you can do the CTO, you can try integrated wire escalation, but I think this is a long CTO, calcified, probably this recanalized thrombus. You have a lot of difficulties probably using integrated wire approach. Also, you can modify the proximal cap, and you can do ADR. ADR, it's tough because you have a landing zone. You have some disease in the landing zone, and probably it's a tough case to do a very good function in before the crux, because you have a lot of disease in this right. You can do, you can do integrate wide escalation, you can do retrograde, and you can do IDR. For me, when you are keep in mind the safety and efficiency of the procedure and also the risk of the patient, I will start with the retrograde approach directly.
Okay, very interesting what you say about the indication. If I remember, okay, I think that in the MRI there is viability in that inferior zone of the heart, so depending from the right coronary artery. So we suppose that maybe Javier and Jose Antonio think that there is going to be some improvement if they can open that right coronary artery. But I agree with you that this dilated myocardiopathy as the first diagnosis of the patient. So maybe what we are seeing is just the last part of the historic or history of this disease, no? Because also MitraClip was performed, resynchronization. So, but I'm still a little bit worried about that 25% of LV function and going and approaching the case in a retrograde fashion. I know that it's really difficult, but anyone could think about doing this with some kind of hemodynamic support, like Impella, or what about your opinion, Bernat?
I think it's a good question, the Impella for this patient, because a patient with 25% left function is very, very difficult and very risky procedure. I think I will do with an Impella. Then for the strategy, I think there are three strategies. I start always with integrated approach, only for preparation if it's needed. And then my second, in a few minutes, I will go for retro for this epicardial collateral. Septal seems that they're not connect, but always we can do an injection selective to ensure that there are no connection because it's safety than this epicardial collateral.
Any opinion about crossing this epicardial connection from the LAD to the right to the PDA? Because many times that you can see the collateral, you cannot cross that collateral. I mean, and sometimes that epicardial collaterals, you may have an spasm there. So, in my opinion, although there are not visible septal collaterals, maybe could be a good case for just trying to cross, because sometimes with a scion wire, you just go straight forward directly, and they are not visible because there is a very big channel, epicardial channel connection. So, Antonio, what's your opinion about the case? How would you approach this case? Would you try to give a try to this case, looking at the clinical case from the beginning to the end?
Okay, I have no doubt about the clinical indication of this CTO. You know, the patient has severe ventricular dysfunction, probably. It could be treated before, and about the approach of the case, it's known when you see a very huge epicardial collateral like this, you wanted to cross it because we are not used to see a huge epicardial like that. No? But I've seen some connections in the antegrade vessel, so probably I would try first antegrade, and if the patient is 81 years old, 25% of ejection fraction, I would try to earn as much contrast as I could. Probably the microcatheter, I would use it to inject for testing distally, and if not, of course, use that huge epicardial retrograde. You know, that's my opinion.
Okay. What about Pedro from Lisbon?
Well,
hello.
Good morning. Thank you for the invitation. Well, I also have some doubts if this worsening of the ejection fraction has anything to do with the CTO. So I'm not sure if the patient will get better with this PCI, but I understand that we should at least try to give some benefit. Regarding the approach, I'm not sure if the retrograde approach, the direct retrograde approach is the safest way, because this patient has 25% ejection fraction and he cannot tolerate any ischemia in the LAD. So if you get ischemia, it can be a problem. I don't have experience with the impeller. We haven't got it in my hospital, but I will feel safe with some kind of hemodynamic support, because this patient, as I told, I think that if it's a long procedure, he cannot tolerate, mainly if there is some spasm. But even with all the material in the LAD, it can be a challenging situation, and it can deteriorate during the procedure. So I'm afraid about that. Mm-hmm. And I would try. It's a very difficult antegrade approach. This kind of situation, usually you cannot cross, but I would anyway I would try, because if you act so sexual, it's much. I think it's much safer than a direct retrograde approach. Mm-hmm. That's my opinion.
Yeah. I think that there is at least at the beginning, there is a small consensus between nearly all of us about the approach. And also we are all concerned about safety with that ejection fraction. So as we have already scheduled the first lecture at 10 o'clock, maybe it's time to go back to the cath lab to see how Jose Antonio and Javier are going, and start at 10 o'clock with the lecture. Jose Antonio, Javier, can you tell us something?
Yes, Jose Ramon, as you can see, we're struggling with the epicardial collateral. It's not as easy as many would have supposed. We thought it wouldn't be easy, of course, but we thought that precisely because of the condition of the patient, it could shorten the time and it could decrease the amount of contrast. Regarding what has been discussed, I would just like to point out that the magnetic resonance, as Jose Ramon has correctly said, showed viability, and we all know, and it has been quite well established, that collateral circulation is never as good as anterograde circulation. It amounts, in the majority of cases, for not more than 40%. So, first of all, that is a thing. And regarding indication, we are not sure, of course. We agree with all the concerns that has been said, and I would say do not jump to increase the left ventricle function with a CTO procedure because it's doubtful. But this patient is not new. We have been fighting. It's a long distance run. We have performed a mitral clip. We have performed, optimized the medical therapy. As you know, or maybe you know, we are a heart transplant center. We are specialized in this kind of patient. We have also resynchronized the patient, and the patient is steadily going down. So at the end, we have decided to try this. It's a question of balancing the risk and the safety, and we will lean towards safety today, with your help, of course.
Okay.
In the meanwhile, I can tell you the setting. Jose Antonio has been working. We have started the procedure with a sesion wear up to the apex, and then progress a Carabel that you know, Carabel microcatheter, as you know, is a very low profile and very flexible catheter and ideally suited for epicardials. And then we have tried first with a SUO. And as you can see maybe on the screen, I don't know if you can see the screen.
Yeah,
right now, can we?
At the right bottom of the screen, you can see we are now in the most angulated curve. We are
trying to tackle.
We are seeing a fixed image, but not the screen.
Yes. Yes, but the fixed image, I think, shows a U curve, and that is the point that we are trying to tackle right now. We are going we have used a SUO, then changed to a sesion with care and even a whisper wire, trying to see if it slipped through, but not. And we are working a little bit, so I think it's a good point. If you have any suggestion to do it, and then we can hear the lecture, I'm sure it'll be very interesting, Jose Ramon.
Okay, just only some issues before going to the lecture in terms of approach. Can you explain us and can you tell us which seats have you already chosen, guiding catheters, and also another interesting thing, if you already plan to go via the epicardial channel, did you cut the guiding catheter? Did you shorten it? Could you comment something?
No, we did not. We have two long destiny sheets.
Okay.
They go up, they turn around the crook of the aorta. So we are in the ascending aorta with both destinies. As you know, I've shown in the initial presentation the tortuosity. And then we are using 7 French because we are obliged, due to the sheaths, we had only 7 French sheaths. We are obliged, so we are using 7 French guiding catheter by Asahi. We have extra backup, is that right? 4 in the left coronary artery and AL1 in the right coronary artery. We have, I think, a good backup force, and we only have to negotiate the turns and the bends, and if not, then we have to go for a second plan and maybe go anterograde.
Okay, did you cut the retrograde guiding catheter?
No.
Is it shorter?
No.
No.
No, we think about using a extension catheter in the right coronary, so we don't think we have to cut the guiding catheter. I think it will be okay with the extension catheter.
Okay. Okay.
Any suggestions before by the panel?
No,
Pedro, João.
Sorry?
Bernat, Antonio. At this point.
What?
Keep going in the retrograde. I think for me, it's the safety, because you have a long channel. You don't have disease in the left system. Okay, this is not a 3-vessel disease. You have a left ventricular dysfunction, but it's not a 3-vessel disease. You have a big vessel, you are in the critical point, because in tortuosity, of course, but it is short. You can go very slowly with the tour, with the caravel, and you can go success. You can have success. For me, it's the safe for the patient, and you can save the contrast media if you are doing this case as a retrograde approach. If you are trying to do retrograde approach, you are in problem. You have a big marginal branch. You can lose this branch. It's a key point for the retrograde approach. You keep it in mind, because you have a lot of calcification. You can see very well the vessel shifted to. You can see where you are work, where do you have to work. But I think it's retrograde, once again. It's the most safe for this patient.
Thank you,
okay,
João.
perfect. So we are going to leave you working with and dealing with this channel. Maybe, João, you can start with the first lecture, which is going to be CTOs in the COVID era. Do you agree?
Thank you very much.
Yeah.
Okay. Thank you very much. Good morning, everybody, and nice to meet you. As you can imagine, with the COVID-19 has introduced a new complexity in the cath labs. This is sure. You guys in Spain and Italy, you know very well what I'm telling to you. And above that, we have bring the discussion how to continuously strive for the best treatment for CHIP patient, mainly CTO patient, regarding managing time, regarding length of stay of the patient in the hospital, and other constraints regarding healthcare workers' infection, the material for protection, and so on. Also, COVID-19 has reduced cardiothoracic surgery capacity. First of all, because we have some hospitals have a lot of ICUs full, the theater staff are redeployed, the post-COVID is vicious and combination, as you can imagine, and interventionally will be asked to take one more complex 3-vessel PCI and CTO, and will be asked, how can I achieve the best result for this patient? This is the most important question that we are faced in this situation. how can I achieve the best result for this patient or for each individual patient. APIC published 3 recommendations on activity in the cath labs in different phases. Phase 1, this is the primary one. And the second one, it is with the peaks of the pandemic. It's about when the Portuguese state started the state emergency. It's March 15. And the main objective is to keep the primary PCI ongoing all the time. And also you have some incentive regarding the people to treat and semi-stable patient, regarding and STEMI patient and chronic heart disease in STEMI, and also from semi-structural heart disease, mainly aortic stenosis, symptomatic. This is the points that we have. You have no minor restriction in activity, point 1, the major in point 2 and 3, the stopped activity. Also, with this kind of the recommendation, we keep 2 points very on time. First, emergency, extra-hospital emergency all the time are function. We don't have problems with the national emergency service, and also we don't have all of the cath labs are working. This is very important, and during this period of time, we don't have any interventional cardiologists with COVID-19 positive. This is a good point. And surely in the first part of the recommendation, as you can imagine, CHIP patient and CTO, all of them are stopped activity in different phases of the pandemic infection. But when you are looking at our national registry of interventional cardiology that we started in 2002, we have more than 1,050 patients. We are looking at a problem between 1 March and the 18 March. We have a reduction in primary PCI, about 23% of the reduction in primary PCI. But after you have the Portuguese government start the emergency, okay, now you have a reduction about 44%. We are very struggle with these numbers, and we did a lot of work with our APIC media, did the hard work in this field. You have a lot of presence in TV, 70% on TV, journal, press. You did some press release, and you did our job in the social media. And you are going to look in the left of my slide, between 1 April and 15 April, with this work, you can capture the percent. The difference between 2017, 2018, 2009, and 2020, we have just less than 2% of primary PCI. We capture the patient because we have now an emergency department working all the time. And between 1 March and 15 April, we have a diminution of the 17% of primary PCI. This is mainly because the March. This is where you have to see to you the lot of work that we did in the media. Now we are preparing a new paper how to restart the cardiac invasive procedure of COVID outbreak. This is also, you have very careful regarding between 1 and 2 weeks in stable patient, we can treat last remaining vessel PCI. Between two months, we can start our program with the patient with CHIP and left ventricular dysfunction, and beyond 2 months, we can start our CTO intervention. As I told you at the beginning, it is the key principles of indication and techniques of chronic total occlusion for managed relax and some of our colleagues. And the main indication, you are going just to talk about the clinical indication for CTO PCI, and the main is to improve the symptoms. This is not for the prognostic. as you know, when you are talking about the CTO PCI, you are clearly, we have ameliorate symptoms and also the quality benefits. We have a lot of trials that you can show this point. Also, we know very well when you have success in opening vessel, we reduce mortality versus when you fail the procedure. Also, when you have CTO as a non-culprit STEMI, double the mortality risk for acute myocardial infarction. This is why you keep in mind you have to do better in the CTO patient. And probably you have potential increase of left ventricular function in ischemic cardiomyopathy and viable myocardium. Probably this is the case. We are going to wait. And also, I think you can reduce the potential risk of arrhythmia. We agree in the optimal revascularization for this patient. Patient with coronary disease should have optimal revascularization by PCI or for CABG. If you have viable or ischemic myocardium, or you have a less than 50% of left ventricular maximum with residual ischemia. I'm just going back to a trial that the intervention was not very good represented, and also CABG is not very good represented. This is the syntax 2 trial. As you know, when you use physiology, you can simplify the PCI strategy, as you can see in this lesion treatment and cause of the vessel diseases. And also, if you use the imaging, intravascular imaging, you can have more better results in this patient. Mainly in the CTOs, if you can optimize the stent implantation. This is the key point of the long-term prognosis for this patient. And also, where are PCI gone wrong in the past? As all of the people are treating CTO, the mine is when we perform incomplete revascularization. This is the point. The most important, the best treatment for this patient is complete revascularization. It's independent of the anatomical or physiologic indication or type of the revascularization. What does it mean, complete revascularization? And also, is the CABG the better option for this patient? Sometimes you have a lot of patients that don't have a target for to implant the vessel. And what you can do about the meta-analysis of complete versus incomplete revascularization? You have a lot of studies that have very small proportion of functional study and numeric multiple definition of complete revascularization. What is the role of CTOs in this situation? And you can, as you can see in this slide, when you do the best for the patient, once again, if you perform complete revascularization. But man, 70% of the cases we did incomplete revascularization. It's why the patient is not going very well. And when you are looking for syntax and CTO revascularization, you have a very poor outcomes with PCI. Why? Because the interventional cardiologists, they perform no perform CTO and 51% of the case. Half of the case, they don't do CTO. What is the paradox for to not to do the best treatment for the patient? But also in surgery, 1/3 of the patient with FCTO, they don't dendrograft this vessel. This is not good for the patient. This is why the patient came back with angina and the worsening left ventricular dysfunction. And the more complex the case, the higher risk of the residual syntax score. And you can show what is the biggest issue in the higher residual syntax score. This is the CTO. As you can imagine, this is 5 points when you don't revascularize the CTO. This is a paper from the Philippe General. And when you are talking about the multivessel disease and CTO and or SHIP patients and CTOs, the complete revascularization, you can do and must do better in 2020, particularly in COVID area. We need to put the PCI strengths together. We need to put the patient centered in our approach. We need to have a very good art team discussion. We need we have now better risk stratification as you have syntax score. We have now very, very good plaque modification, whereas you can rotor pro orbital tracheotomy, intravascular lithoplasty, scoring balloon, overin. You can do the revascularization and ischemia revascularization, EFR, FFR. You have a very good new generation of deglutining stents. You can do the procedure guided by imaging, IVs or OCT. And also, when you are a hybrid operator, you can have success more than 90% of the case. This is what you have to do and what to keep in mind in the current practice in 2020. My take-home message at default, complete revascularization should be considered mandatory in multivessel disease and CTO practice. Optimal vascularization means open CTO where myocardium is viable or ischemic. And it's very important for CTO operator. Almost every lesion can be treated, provided you have the right skill and the tools. And complete revascularization with contemporary DAS led an excellent short and long-term outcomes. Thank you very much.
Many interesting things that you have already said, because this pandemic is something new for all of us. So I think that the most important thing, the most important thing is maybe something that what you said at the beginning, and we have all experience in our cath labs, and it's the problem with the emergency cardiological patients, how those patients did not come when they had to come to do primary PCI because of myocardial infarction, and we all experience a decrease in the treatment of this type of patients, and the consequences are really a disaster. The consequences is death, mainly. So I think that we had a greater decrease than what you have in Portugal, because maybe the pandemic hit greater here than in Portugal. But something that I really agree is that we have to stop this kind of CTO patients that are maybe with a stable heart disease, ischemic heart disease. I mean, and resources had to be focusing some other places of medicine, no? I mean, so what's the opinion of the panelists? Bernat, Antonio, what's your opinion about how we have treated our cardiological patients in this period of pandemic? Are you happy what the health system have done with those patients? What's your opinion?
Well, in our hospital, the patients, the cardiological patients, come later than before the pandemic, and it's a problem for us because they arrive worse. But when they arrive, the treatment we do is the same than before. It's certain that we only treated the acute patients, the chronic patients who stay at home, and we are now restarting with them.
Okay, José Ramón, I want to say that it's not depends on if you suffer more or less pandemic in your area, because Huelva suffer very few patients of if you compare with other parts of Spain, but cardiologist patients feel the same panic of coming to the hospital. So hospital was alone. So we did the same during this period, just only acute, but we started to do some ambulatory patients probably before than other parts of Spain, because we start to feel that patients could come to the hospital and they were not coming, Not total occlusion, of course, because as you have said, resource probably should be used for other things, but I completely agree with you. So.
Okay, Pedro,
well,
how did you suffer the problem in Lisbon? Everything stopped there?
Yes, we stopped everything. We kept doing just emergencies and urgencies during some weeks, but we did restart, and we are working on full time now. I think the patients are coming back. They are not so afraid now. But at the same time, we have a particular situation in my hospital because we already faced some difficulties during this, namely CTOs, because we have a high volume center, but we will need to have more cath labs. And so even before the COVID era, it was already difficult to have time to do CTOs. And so now it's even worse, of course. So we didn't start to do CTOs yet. Hope that we will do it soon. But we are doing the patients who are already waiting in the waiting list. And we didn't finish yet.
Okay, I think that Javier, José Antonio, can you hear me? How are you going?
Yes, we have
changed our micro because I'll show you. We were stuck with the micro in the curve. We couldn't advance the carabel. So we have changed using the trapper balloon. We have changed for a Mamba Flex just to try to advance a little more the micro. And now we are engaging again the vessel.
Quizás tiene que hacer una curva.
Joder, ¿dónde está el Mamba? Está a tomar por saco, Ahí está. I don't know, what do you think?
So you exchange for the Mamba?
Yeah.
Mamba Flex.
Mamba Flex.
Okay, Mamba Flex. I couldn't hear. I couldn't hear why. Sorry, I had to close the door.
Olga, dame toquecito, por favor.
A ver. Just a minute. We're going to check our position.
Okay.
Okay. So why? Because we managed to pass the U curve with the SUO wire.
Yeah.
Not very far, that is true, but the caravel could not even insinuate into the first part of the U. So we thought maybe trying a different microcatheter, maybe with a different flexibility. And it was also true that the caravel had been quite a long time in the position. So.
So which wire are you using now? Is it the SUO again, or?
No, we're using the sesion only to go to the epicardial vessel.
To the original position.
Okay.
Ramon,
what?
Sorry, I don't know if you feel the same when you have a huge epicardial like this. You need navigability of the wire, but you need even some support to progress to advance the microcatheter.
Yes, yes, we did.
don't you feel that sometimes helps you more scion than suo in as big epicardia like this?
Well, it depends.
Yes,
Okay, Javier.
that is true. In this case, let me say, we are considering using an extension catheter because the guiding catheter does not give us a lot of backup support. So that could be an option in this case. However, we are worried, as you know, by the fact that this patient has severe LV dysfunction, and we do not want to have a lot of space occupied in the left coronary artery occupied by catheters. So, sorry, José Ramón.
Yeah, just only some comments. If I had to do this case, I would have cut for sure the guiding catheter. Okay. I think that I would have chosen 7 French, the same as you, but I would have cut the guiding catheter because even if you use an extension guiding catheter for the antegrade approach and trying to shorten the length, you may have sometimes surprises. So another interesting thing is something that Antonio said. I usually try the scion wire, the regular scion wire, and if there is a very big tortuosity, I change to the suo. If suo cannot cross the other option that I usually use, and I nearly do always the same, is to use the scion black. I think that the scion black, in terms of sliding, ability to cross those tortuosities in the collateral, many of them epicardial, is really very good. So and the other thing is that sometimes the wire goes, but the caravel doesn't go because the support of the micro is not very big, and it prolapses. You know, so if you do not have a lot of backup support, it's going to be difficult to go with the caravel, even though it is thinner than some other reinforced microcatheters like the Corsair or even the Mamba Flex, which you are using. Something also interesting is to use, in my opinion, is the trap liner in an antegrade and retrograde fashion also, because trapping maneuvers are easily and faster done. So these are my comments about the approach.
Yeah, I'm agree with you. My first choice would be suo. If it fails, I'll change for scion black. It's very, very good for epicardial collateral. Also, you have to very careful. You need to be patient with the conjunction between caravel and suo. We need to walk very close, caravel and suo. Yeah. It's very important to navigate in this tortuous vessel.
Yeah, and sometimes if you are very close to the...
You need to take time and patience.
Yeah, sometimes if both tips, as you said, are very close, sometimes you can move the whole wire and micro and navigate with it along the tortuosity, and sometimes it jumps. So,
very simple.
Okay, so how is it going?
So, José Ramón, we much appreciate your comments. In fact, we are going to try the scion black. I think it's a good idea. It's a polymeric wire with very good control of the tip. So I think we are going to try. We are just advancing the sesion black.
Yeah. Anyway, I wouldn't forget the septals that sometimes are invisible. They are just not visible because the connection through the epicardial channels are so huge that they are not visible, but they are there. So.
But at that point, they don't put the patient on risk.
Sorry, Joe, I didn't get what you said.
At that point, they don't put the patient on risk. The patient, the procedure is safe now. Most important is to be patient. We need to do the things very slowly. Because it is epicardial, big epicardial. You have a problem in this big epicardial, you are in trouble.
Yeah, I think that this is really very important. The message that we have to give to the attendees is that safety is the first issue that we have to look for in every patient, but in these patients that have LV dysfunction, like 25% in this case, safety is the main issue. I mean, perforation or some ischemia in the left system could be a disaster. And I'm sure they are going to perform it perfectly well. So.
Was our main concern from the start, the safety. We anticipated problems with the tortuosity, maybe not as much as we are having, and we have to be patient. The question is how long do we have to be patient, and when to change before stopping becomes inevitable. Right now, I can tell you we have about 180 cc's of contrast. The patient has a normal kidney function, and we've been changing projections, so I don't think the
pressure is okay also.
Yeah, the patient is stable with 97% saturation, and well, I think we can go on, but maybe we'll have to put a limit to the.
Yeah. Regarding safety, I think you talked before about extension catheter to improve the support, but I don't think it's a good idea in this case because it can be quite a bit dangerous to force the wire with a very high support. I think in these cases we have to be extremely careful and not force too much.
Yeah, just only one comment about that. The extension guiding catheter, even if you leave it inside the guiding catheter without putting it outside, it increases the backup support nearly between 15, it depends on the case, but between 15 and 20%. So you do not need to put out the tip of the extension guiding catheter even. So this is something that it can be
advance the micro, okay?
Interesting to know.
Be careful with the tip of the guide wire, okay? This is a sign black, okay? Okay, keep going. Okay.
We have 40 attendees in the meeting, in this virtual meeting. And I want to remind you that we have a chat in the Zoom that is really very easy to to use, and if you wanted to ask any questions to the panel or to the operators, you are free to do it. I mean, this is something that is supposed to be
Good.
useful for everybody and to perceive. So you can send any questions and we can discuss it at any time.
Go. It's good. Good.
And to advance the Mamba.
Yeah.
But it's tricky at this point with that curve.
Yeah, you can spin. You can spin slowly.
Yeah.
Which wire are you using now?
Doesn't work.
Fine black.
Fine black.
Okay, that's okay. That's perfect. Keep going. Keep going.
Yeah, usually the cyan black has to be moved with fast spinning.
Yeah.
Yeah, keep going. Keep going. It's good. Good.
And it's important when you have the wire or any wire in the in a channel, mainly in an epicardial channel, not to have a loop at the tip, because those loops may cause some dissection at the channel and have problems with the retrograde flow to the occluded vessel.
Regarding what you are saying, I don't know if you agree, but probably I would like to have much support to cross the wire regarding the excitator, but I would like, once I cross with the wire, it's safer to have much support and to be able to cross the micro catheter. But to cross the wire, I'm not sure if I want much support, because it can increase the risk of dissection, as you were saying.
Yeah, yeah.
Can I ask a question to the panel and to José Ramón?
Instalación black. Sure. Instalación black. Sí.
Would you have coils as backup in this case, or in any case, in all cases? What would you plan if you have a perforation? What would be, how would you manage?
Good question.
Yes.
Coils for sure, always. I mean, at least let's see what the panelists think, but we should have in our toolkit prepare coils for any of the situation that could have happen in cases like this one. Another problem is that if you have a perforation in a collateral channel as big as this one, giving so much of flow to the occluded vessel, and we occlude the vessel with 25% of LV function, we are going to have a mechanical problem. In this case, not only the perforation, but the lack of flow to the occluded vessel, which is viable. But always prepare with coils. Sure. What's your opinion, Joao, Pedro, Bernard?
It's one of the most important of our toolbox.
Yeah.
Well.
Yeah, of course.
And covered stents also. Not
sure.
For this. Covered stents can be found nearly everywhere, but not coils. Not coils.
No.
It's not so easy to find coils in some parts of the world in the cath labs.
The problem of an epicardial like this is that usually epicardial have more collateral for other part, you know. Probably you can embolize with coils from the LED, but you have a conal ramus that gives perfusion to those distal vessels. So it's a problem. Yeah, it's much better don't to have a preparation. No?
Yeah, great point. Sure.
Yeah.
This is why I usually try always septal collaterals, just to do surfing, and you find many situations where you can connect.
Don't test a lot because it's a critical point. If you are in the dissection, it's finished. Just leave the guiding, the guide wire, keep going. If you test a lot, you can take a complication because now it's time.
Okay, I think that we are stuck here in the channel crossing maneuvers. Maybe we can change and leave Javier working there, and we can change to Valladolid to see how are they going. Maybe we can comment some issues about the case and leave Javier and Jose Antonio working there because sometimes you need time and you need nobody say what you should have to do. So Nacho, Alfredo, can you hear me?
Yes, I can hear you. Can you see us?
Yeah, perfect. We can see both guiding catheters.
Okay.
Maybe it could be a good time to see the case that you are going to do and start with.
Thank you very much, Dr. Rumoroso and all the panelists. I'm in the CAD lab. I'm Dr. Amat. I'm with my colleague Alfredo Redondo. Jesus is with us, is our nurse, and also we have around Lorena and Alba, who are our nurses, and Rosa somewhere. So we have had some challenging start because of the vascular access. We will discuss it later, but first of all, I'd like our fellow Sandra Santos to present the clinical case, and so that you can discuss a little bit about it. Please, Sandra, can you proceed?
Okay, so this is the case that we have planned today. It is a 70-year-old male. His background, he has high blood pressure, he has type 2 diabetes mellitus, he's obese and a smoker. He was on stable angina from February, and he was not in a study because of the pandemic. He has preserved ejection fraction, and he has no well motion abnormalities on the echo and without significant valve disease. In the cath lab, we have seen he has a mild LAD CTO. He has disease on the second diagonal, the intermediate artery, and the right coronary artery has disease on proximal and distal segments. We have calculated these scores for the CTO, but I think it's better to see the angio.
Yeah.
We can hear the right coronary artery. The patient has disease on the proximal and distal territories. We can see the collaterals to the LAD. And on the left angio, he has a severe coronary disease with the CTO on the LAD, disease on the proximal intermediate ramus, and significant disease on the circumflex. In summary, we have a 70-year-old male with diabetes mellitus, 3-vessel disease. He was told to surgery to make a 3 cabbage, but he refuses to surgery. The patient didn't want to do this approach, so we have planned to perform LED PCI and this is the approach for today.
Okay, another very interesting case, very different to the other one in terms of coronary disease and also indication. Nacho,
Hi, Jose
can
Ramon.
you tell us what is your plan, and then we can comment about the strategy.
Sure.
About,
I could not hear you very well, but I think Sandra already mentioned that we have been considering surgery in this case.
Yeah.
The patient is not very interested into surgery initially, and this is why we have decided to try. Normally in CTOs, we treat before the more simple lesions, so here the marginal, the right coronary artery, but in this case we are starting with the CTO because the distal vessel is good, so if for any reason we fail, which I hope no, then we might consider surgery for the 3-vessel disease. Here we only have antegrade alternative from my perspective, and this is the dual injection catheter in a caudal view. You can see we have a samurai wire in the right coronary artery to give support. We have had many issues with the vascular access because the right coronary artery catheter is from left radial. In the coronary diagnostic that we did a few days before, the support from the right was very bad. This is why we are from the left. And in the femoral, we have a 7 French XB3. We have tried an XB3.5, but it was too long. And also we have had to use a long seat in the femoral because it's tortuous and calcified. So we were really having issues to select correctly the artery. So my initial option in a case like this would be advancing dual lumen microcatheter to have some support in the diagonal artery. But here, the diagonal artery is also diseased, and I don't want to cause ischemia. So I'm going to try a simple antegrade approach with a Mamba, not Mamba Flex, but Mamba, to get more support because it's larger. And as Sandra said, we are starting with Judo 3 and check.
Okay, well, many things that can be discussed here with the panelists.
You can see the angios.
Yeah. We have here a 3-vessel disease. What's your opinion about treating all the lesions before going seriously to the LAD? Because also the possibilities that you have maybe are less in these cases. What's your opinion, Antonio, Bernat, Joao, Pedro? You are the top operators here discussing the cases.
Whoever.
What would you do if this case were yours?
In my case, it would be very similar. No, I think that you should offer the surgery to this patient, but for us, the opinion of the patient is important too for us. So, and your feeling, you know, if you feel that you can open that coronary total occlusion or not, that is very important too. It's not written, nothing about that, but I think that is important. And talking about the approach, probably we would do more the same. I think you have you have the branch, the diagonal branch, but you have a small tapery shape distally, so you don't have the branch just blunt with the proximal shape. And go ahead, wire escalation, try to do it better. And probably why not? You have a flow, a dissection re-entry, you can use it too. I think this is another option. Yeah, you can use it. I don't know what you think about that.
Okay, any other comment?
Well, I think this case, I start antegrade, but I don't obvious the retrograde approach. It seems that in the diagonal branch, apical, the connection is just very small and tortuous, but you can try. Sometimes you can go for this. And from the right, in the marginal branch, you have a connection too, but I will try the septal because that in the previous case, you don't know if the septals connect. You can have to try and surf because you can have a surprise.
Okay, Pedro, Joao.
Okay. Well, first of all, I think that this is a trivessel disease patient and a diabetic one. And more than this, I'm not sure if the left main is also diseased because it has it's smaller than the distal vessels. So it's another issue. And beside of that, you would have to treat the intermediate vessel, which has disease from the ostium. So we will have to reach the left main. So for me, it would be probably a surgical patient. But if you go through if you decide to do PCI, I think it's an retrograde case, first of all, because I think that there is a stump. You can see it in the spider view that you have. It's not a very ambiguous proximal capsule, and you can go antegrade wire escalation. You can do antegrade wire escalation. You can do dissection re-entry. You can use double lumen catheters, and I would go for retrograde approach only if it's really unsuccessful, because I think that the epicardial collaterals are not very good. Well, we can't see very well, but I think that the epicardial from the diagonal is very tortuous, and the same, I think that the one from the right coronary artery is also very, very tortuous and very long. So I agree that we should try first of all, an integrated approach, even with maybe with a dissection re-entry, because you have space even to do a crossbus, to use a crossbus, for example.
Yeah, this issue that you commented, Pedro, is really very important. The left main has disease. I don't know if you perform IBUS when you did the diagnostic catheterization, or what do you think about the left main that you are working there, Nacho?
So we have been discussing a little bit before the procedure based. Well, this is the vascular access, and this is the first angio, it's a caudal one. I think the left main has not a significant disease, but it is true that the marginal has a severe disease, and I'm not sure if we can treat that and the LAD without going up to the left main. I don't think there is significant disease in the left main.
Okay.
This is where we are now, if you want to check. This is our last angio. We have the Mamba and a judo 3, which has advanced quite a lot in the structure of the vessel, but it's very, very calcified. Yeah. The support of the Mamba was quite good, but now I think I need a better profile to cross. I'm going to try with this, but I might de-escalate to Mamba Flex.
Okay, that's a good point.
Can I?
Yeah, sure, Joe. Okay. Please.
Okay. First, I think it's a very good clinical indication for revascularization. It is clear, okay? Previously disease, you need to do revascularization in this patient. For me, the most important is which is the best treatment for this individual patient. I'm not very sure if the surgery is better in comparison to PCI in this patient. You will use IVUS guiding imaging, intravascular imaging, and physiology, okay? Regarding the technique, the procedure, I think we have all of the possibility to do these cases and to do the complete revascularization at the end. You can start, for me, the easier way to do this case is to start integrated wide escalation. Probably I can start the Fielder XTA or Fighter. If it's going well, okay. If it's not going, I can escalate for 2 Gaia second because it's a true lumen. Judo 3, it's we don't know very well what is the position of judo today. It is not the same from the Gaia family. Gaia family we know very well. That is a very, very controlled guide wire. It's very, but it's a true lumen, not the plaque, interplaque, or 70 mile guide wire for true lumen. You can use, sure that you can try integrate the session re-entry, but also you have a very good intervention collaterals regarding the septal and also for the epicardial, from the sock and from the diagonal. But you can do this case when you, the most important is which technique or which technology you can use and which technique you are more comfortable with.
Yeah, that's a good point. Why did they use the Judo 3 to start with in this case? Which could be the strategy of choosing wires in the antegrade wire escalation? Because there are many type of strategies and schools at the end. We have a question from our good friend from Mexico, Nasser. And Nasser is saying something which is really interesting. The diagonal branch is disease. We have a disease there, and could be a good point to put and to cover that branch with a wire that in terms of safety, any problem that could happen in the bifurcation with the LAD could you could have some problems with ischemia in that territory. And also, if you could use that branch to do IBUS to guide a little bit the entry point, or you are sure that the entry point is clear in this case, Ignacio?
Protect it and to treat it as well, but I have a 7 French catheter. We were considering 8 French, but I was a bit concerned with the left main and an 8 French. Indeed, the catheter is in and out all time, and also the access has been really challenging even for an 8 French. So this is why I prefer to have a 7. But now for the trapping and everything is being a little bit tough, and if we have also a wire in the diagonal, this will be problematic. I know what Dr. Rumoroso is thinking. You should have used 8 French, but it was really challenging, I promise.
Well, yeah, I mean, 8 French could be used in this case. If you have problems with the left main, you can always put a wire in the aorta to prevent the guiding catheter tip to hit the left main. And it gives you support enough, and you can also be safe because you are out of the ostium of the left main. In my opinion, this could be a good case to do and to work with a dual lumen microcatheter, because if you put a wire in the diagonal branch and you are going to be sure that you are going to at least have a wire there just in case that you have problems. And it could be also a possibility of increasing the tip force of the wire that is going to try to enter in the LAD. The higher the support the wire at the side branch is with a dual lumen microcatheter, the higher the tip load of the wire you have for the antegrade wire escalation. So in this case, I think that it could be a good case to start with. Another thing is that every time that you work with a dual lumen microcatheter, is you should have to do many times trapping. So if you want to do it in a fast way, it's very useful to have also a trap liner inside, and you do not have to put inside and out a trapping balloon. What do you think about the bend that you have with the wire in the LAD? Are you comfortable with because we cannot see perfectly well the landmark of the calcium, but what do you think?
I think this bend might show that we are around the vessel. Yeah. I'm not sure because in one injection here, it seemed like we were getting close. We are close to the calcium. This is a right projection and cranial. But when I went to the next one, I don't like this bending. It seems like it might be entering some septal branches or so. This is still the judo 3, so I'm working on the plug. I want to prepare this, but I'm having, as we expected, it's been really tough to advance the microcatheter because the calcium blocks it. You see, we started with Mamba to have more support. We were able to cross the proximal cap, so it did the work, but now the work of crossing the lesion is being much more tough. So maybe it's the point, as you said, to consider a dual lumen catheter. But I want to verify where my wire is before changing the catheter.
Nacho, okay. I'm Antonio from Huelva. Don't you think about using a microcatheter with more pushability? You know something about Corsair or spiral surprise?
Another option. It is another option for sure. What I'd like to do is try to advance a little bit this micro and maybe escalate the wire, try again to cross on a stiffer wire with the micro, and if I cannot, I will change to another catheter. I'm still doubting if using the branch.
Okay, we are going to leave you working a little bit there. Just a very short connection with Hospital Puerta de Hierro in Madrid to see how they are. In 2 minutes, Dr. Bernat Serra will give us his lecture.
Hello, Jose Ramon. Can you hear
Javier?
Me?
Yeah?
Yes, well, I can tell you, maybe we can look at the final pictures from the retrograde approach. We did manage to make some progress, but the curves were too much for the microcatheter, and anyway we couldn't go any further with the guide wire also. So we were very, as I told you before, as you have mentioned also, we want to lean towards the side of safety, and we were very much worried with inducing a small dissection, and we stopped. So we are going anterograde right now, and that's where we are starting. Maybe Jose Antonio can show you where we are right now. No, that's not where we are. So we are with the guide wire and the microcatheter beneath the origin of the right ventricular branch that has a relatively tight stenosis in its origin that we, at the present moment, we do not want to touch. And we have the microcatheter, and we are going to start with, well, Jose Antonio is going to start with a fighter wire. We will escalate and try to go smoothly and safely, which is our prime concern.
We have, as microcatheter, we have a Mamba Flex that we have just put in the entrance of the short one. Yeah. And as you speak, I'm going to move. What can you ask, please, the panelists what they think? Would you use the same wire? Would they try a harder wire?
Yeah, they are hearing you. So, any comments about the strategy? We have 5 minutes to comment. Which wire would you choose, Antonio?
I would choose, yeah, probably a fighter or a Fielder XT with a Mamba Flex is right now for starting. So
okay.
I will see.
Joao, your first wire here?
Yeah, I'm agree with Antonio. I can try fighter because fighter they have 1.5 milligrams in tube. Probably it's better than Fielder XT. But I have some doubts because we have a lot of calcification in this part of vessel. I don't think so if you are going to succeed with this strategy. By the other time, you have a big side branch. You will be very careful with this branch. It's very important to do not lose this branch.
Yeah. Pedro, Bernat?
Well, I will start with the fighter or Fielder HTA, and then I think I go up for a Gaia in the next step.
Yeah, I agree. I would use the same wires, an XTA or a fighter. Regarding the microcatheter, I'm not sure. I don't have experience with the Mamba, so maybe I would choose a soft microcatheter than escalate if it was not possible to advance after crossing the wire. Regarding a dissection reentry strategy, I would be also afraid as drawn with the posterolateral branch because we shouldn't lose any branch at all in this patient. And I'm not sure if we can re-enter before the crux.
Okay. It's not good because we have a lot of disease in this town RCA.
Yes.
The re-entry point, if you are using RGR, it's before just 3-5 centimeters before the crux, because at this point you have a lot of disease.
Yes, but you have a lot of disease before the crux, so it cannot.
But you have a landing zone 10 millimeters, 15 millimeters. You can do a punction. You can try antegrade wire escalation to find space and to create space, but I think you need probably the more penetration force of the guide wire, because you have a lot of calcification. You have this is a thrombus, the canalized thrombus with calcium. Yeah. It's not. You can find the channel, but after that you need support for to go with the micro. It's very tricky. It's very tricky.
Okay, very interesting your comments. I can also see here in the panel up here in the Zoom platform, there is also Pablo Salinas here. I don't know if he can connect and say hello, Pablo. Hola. Sorry, I miss you at the top of the screen. What's your opinion? What would you use in this case for antegrade approach?
Don't worry, I'm just going online and offline. So thank you for letting me in. I think that for this case, the most important thing is the tortuosity that we have. So that may facilitate dissection very early in the case. So if you are able to stay in true lumen, it will be, of course, the best option. But I think it's going to be very, very difficult. And sometimes you can take the opportunity when you just go 70 miles to throw a knuckle and maybe facilitate the to overcome that tortuous segment. But then you will have the problem of the reentry, of course, and to advance the Stingray or whatever tool you are using for reentry through that tortuosity. But I guess we will have a high chance of going 70 miles here, and I think we just have to take that chance as an advantage and use it to overcome that area.
Okay, yes, it's interesting. The main limitation maybe is the bifurcation, that the CTO deletion is up to nearly the bifurcation of the PDA and posterolateral branch, which are very big. Would you have chosen just to have a try to the septal from the LAD or not in this case?
We usually take septals first, always. But not too much time because there's no clear channel. However, if you happen to find it, you will be always safer than through an epicardial collateral. So it's always our first choice. In our center, we always try septals.
Yeah, that's a good point. Okay, so we leave you here. I think that Dr. Amat had made some advance here. Just before the lecture of Bernat Serra. Dr. Amat?
Yes, so here you see we are with the Mamba Flex and the Judo 3. This was where it stopped, so we escalate to the Judo 6. And this is the Judo 6. You see we made huge progress. We have also escalated the micro. You can see, I think we are in Truman. Yeah. But I've been for a while trying to advance the micro. I tried with the Mamba, could not cross. Mamba Flex could not cross. Corsairs cannot cross. But I have advanced a little bit more. So I'm starting to consider some support strategies, extension catheter or anchoring. But in my mind is from the beginning the rotablation. So if I can advance a little bit, I might try to advance the rota wire. What do you think?
Do you ever turnpike roll?
Excuse me?
Do you ever turnpike roll?
Yes,
turnpike?
Yes, we have. It's a good suggestion.
You have problems with the support of guiding catheter. It is clear. You have a problem of supporting the beginner.
I agree with you that normally it has solved me some tough cases because of calcium. But in this case, I'm not sure if it's going to work because the support of the catheter is not really good. Maybe with an extension catheter in addition.
The first thing is to use a guide extension to improve the support. And after that, you can try. Sometimes it's going.
I take your suggestion.
Yeah, that's a good point and a good issue. Well, for the turnpike goal, you need a very big backup support. So, well, we will leave you here. I think that rotablation is a good option. We can speak later on about tips and tricks that maybe you have to do for exchanging the wire. So, Bernat, to go on time and to follow the program, could you give us the lecture about when not to treat a CTO, please?
Well, I will do the presentation in Spanish because this is for me. El tema que me ha tocado es when not to treat a CTO. Y si preguntamos al especialista en CTOs, él te dirá, yo puedo hacerlo. Entonces el especialista siempre intentará tratar la CTO, este es el punto de vista del especialista en CTOs, pero si vamos a ver el punto de vista del cardiólogo clínico, la cosa cambia. El cardiólogo clínico nos dirá una oclusión crónica siempre es una cardiopatía isquémica estable. Entonces, si miramos el estudio CURAS en el año 2007, nos enseñó que los pacientes con cardiopatía isquémica estable, tanto el grupo de tratamiento percutáneo como el de tratamiento médico, el resultado era igual, tanto en en supervivencia como en eventos. Entonces el cardiólogo clínico nos dirá cuándo hay que tratar una oclusión, pues nunca. Pero si los cardiólogos intervencionistas no hacemos ni una cosa ni la otra, no hacemos ni siempre intervencionismo sobre una oclusión crónica, ni tampoco nunca. Porque si vemos el registro español de hemodinámica, ya en el año 2015, pues 2012, 2013, 2014, 2015, se ve que sí que se están haciendo 2.800 oclusiones crónicas al año en España, que esto ha ido en aumento. ¿Y por qué hacemos esto? Pues miremos a ver qué dicen las guías. Las guías dicen que la indicación para la revasculación en pacientes con enfermedad coronaria estable es la persistencia de los síntomas a pesar del tratamiento médico y óptimo o mejorar el pronóstico de estos pacientes. Y en las oclusiones crónicas pues nos dicen exactamente que necesitamos discutir abrir las oclusiones en los pacientes que están con síntomas, con zonas isquémicas importantes. Entonces, miremos a ver un poquito qué es lo que tenemos hasta ahora de los pacientes a los que les hemos revascularizado oclusiones crónicas, y lo que tenemos inicialmente son muchos registros que nos hablan de la mejoría de los síntomas de los pacientes que han sido éxito comparados con los pacientes que han sido fracaso en la oclusión crónica, y claramente los pacientes que han sido éxito mejoran sintomáticamente respecto a los que han sido fallidas las oclusiones. Si vemos, además de la angina, miramos la mejoría del pronóstico, también parece ser que los pacientes a los que conseguimos abrir la oclusión crónica tienen mejor pronóstico que sobre los que hemos fallado la oclusión. Y esto seguimos viendo, si hacemos no solo registros, sino ya metaanálisis, también todo hace indicar que en la angina sí que mejoramos a los pacientes que les abrimos las arterias respecto a los que no lo conseguimos. Y también aquí podemos ver un poquito en un estudio de Borgia lo que nos indica los factores que hacen que sea más probable que fracasemos. ¿De acuerdo? Y seguimos viendo esto con respecto a la angina, en el pronóstico, pues también lo mismo que íbamos diciendo en los pacientes que hemos conseguido abrir la oclusión, mejoramos el pronóstico respecto a los que hemos fallado esta oclusión, tanto en mortalidad general como en mortalidad cardíaca. Y esto también es un metaanálisis del pronóstico, que sí parece que hay una cierta a favor del éxito, pero respecto al fracaso, pero esto siempre es puede haber sesgos de confusión en estos estudios. Y para todo esto, para intentar solucionar los sesgos de estos, se hicieron 3 estudios randomizados que todos conocemos y que hemos visto, que solo se ha publicado uno, que es el Explore, el Decision CTO y el Euro CTO no están publicados, y entonces con estos estudios podemos sacar una serie de conclusiones. La conclusión más importante es que en un estudio randomizado definitivo que compare el tratamiento percutáneo con respecto al tratamiento médico está pendiente, porque los que tenemos no han sido definitivos, y esto puede ser debido a fallos en el diseño y en el ejecutamiento. El Decision y el EuroCTO no alcanzaron el número de pacientes que habían previsto, con lo cual ya tenemos un sesgo. Además, el periodo de inclusión fue muy largo, con muy poca inclusión de los centros. En centros que tienen alto volumen de oclusiones incluían pocos pacientes, con lo cual también puede haber sesgos en esto. En el Decision también había un sesgo, que había mucho crossover entre grupos. El Decision tenía un endpoint primario que puede ser inadecuado, y tanto el Decision como el Explore una selección de pacientes inadecuada. Y esto que nos ha dado, pues que nos da resultados contradictorios respecto a los metaanálisis y registros que teníamos desde antes. Con lo cual lo que tenemos que hacer es buscar un nuevo randomizado. Ahora se está empezando el isquemia CTO, que parece que tiene buena pinta, a ver qué saldrá. Y lo que sí que es verdad que a lo mejor no tenemos que buscar endpoints tan fuertes como mortalidad o así, porque si ya se demostró en el primer estudio es que los pacientes con cardiopatía isquémica estable no mejorábamos, pues en las oclusiones crónicas probablemente también sea muy difícil demostrar que mejoramos en mortalidad. Y entonces, ¿cuándo tratar una CTO? La pregunta era cuándo no tratar, pero yo pongo aquí cuándo tratar. Pues claramente la indicación más importante es para la mejoría sintomática. Esto es también en pacientes que, aunque no estén sintomáticos, tienen isquemia en territorio importante del miocardio. Cuando hay disfunción ventricular y demostramos viabilidad en el territorio de la oclusión, y lo único que salió un poco significativo en el estudio randomizado fue abrir las arterias ocluidas de zonas no infartadas, en pacientes que tenían infarto, y sobre todo si esa arteria era la descendente anterior. Entonces, el cardiólogo intervencionista, porque pues ¿cuándo hay que tratar una oclusión? Pues a veces, no siempre, tampoco nunca, algunas veces. ¿Y cuándo no tenemos que tratar una oclusión? Que era la pregunta inicial. Pues, bueno, esto es lo que hemos dicho antes, el cardiólogo dice nunca, algunas veces o siempre, pues nos quedamos con las algunas veces. ¿Cuándo no hay que tratarlas? Pues no hay que tratarlas en pacientes asintomáticos, que el territorio es pequeño, que no hay viabilidad. Y sobre todo una cosa que tengo muy en cuenta cuando es si el vaso distal es pobre. Si no vemos un buen vaso distal, pues no nos metamos ahí, porque el riesgo puede ser mucho mayor que el beneficio que podemos dar. Y para demostrar un poquito esto, he pasado unos cuantos casos que tenemos. Este es el primero, un paciente de 83 años, hipertenso, dislipémico, diabético, con una anemia ferropénica, en tratamiento con anticoagulantes por una fibrilación auricular, y que estaba afecto de una cardiopatía isquémica y valvular de larga evolución. En el año 2005 se le puso una bioprótesis aórtica y se le hizo un bypass a la coronaria derecha de esa vena. En el 2014 ya ingresa por un infarto o simulación del ST2 con una función del 40%. Se comprueba que hay una nueva estenosis aórtica sobre la bioprótesis y tiene ocluido tanto el bypass como la coronaria derecha. Se hace un primer intento de revascularización de esta coronaria derecha, que fue fallido, y se implanta una TAVI en valve-in-valve. En el 2019 viene nuevamente por angina mixta, se le hace un SPECT farmacológico que es clínicamente positivo, pero eléctricamente negativo, sin isquemia y con una necrosis inferior. Se le realiza la ecocardiografía, que la prótesis está correcta y tiene una cinesia inferior. Pero a pesar de eso, el paciente está muy sintomático y el cardiólogo nos pide si podemos abrir esa oclusión. El paciente está muy sintomático y pues lo intentamos, a pesar de que ya había sido un primer intento fallido. Era una coronaria derecha que era grande, con un vaso distal aceptable, un primer intento anterógrado, que nos fuimos por falsa luz. Ya se había hecho 5 años antes un intento anterógrado que fue infructuoso y decidimos ir retrógradamente. Con facilidad conseguimos pasar una guía a través de la septal, el corset también avanzó, y aquí en una inyección selectiva vemos que la interventricular posterior no está comunicada con la cruz, es decir, que tiene una segunda oclusión a este nivel. Intentamos con guías a ver si conseguíamos ir, pero se nos iba por falsa luz también, y entonces lo que hicimos fue un knuckle retrógradamente para recuperar la arquitectura del vaso. Y una vez hecho este knuckle, hicimos un knuckle anterógrado y con bastante facilidad hicimos el reverse card y entramos en luz verdadera. Desde la IDP predilatamos, pero una vez predilatado, el problema que teníamos es que la posterolateral no estaba comunicada con esta derecha distal que habíamos recanalizado. Entonces volvimos a hacer un retro por una misma vía septal, entramos en la posterolateral también con facilidad, avanzamos el micro, inyectamos y vemos que ahí sí que estamos en la posterolateral. Conseguimos cruzar fácilmente con una galla sin más problemas. Y después de eso dilatamos hacia los dos sitios y pusimos un stent en la posterolateral. Pero después vimos que la posterolateral no estaba comunicada, la derecha ahora no estaba comunicada con la IDP. Con lo cual pues volvimos a hacer un retro, recuperamos a través de la colateral que ya habíamos hecho la IDP y retrogradamente hicimos otro reverse card y entramos a nivel de la derecha distal desde la IDP, recuperando otra vez el vaso. Entonces ya sí que pusimos stents a toda la derecha, hacia la posterolateral, y nos quedaba la IDP sin revascularizar, que tuvimos que volver a ir retrogradamente, recuperarla, avanzar entonces ya sí con un pipí en el micro anterógrado a través de la guía retrógrada y predilatamos otra vez y completamos con un TAC. Y este es el resultado angiográfico final después de este trabajo. Y la cosa es que el paciente, después de esto, la evolución ha sido buena, hizo una hemorragia digestiva al mes, por lo que se tuvo que tirar la triple terapia y se quedó con doble, y desde los 12 meses todo a Pichalán, y a los 12 meses de el señor está sin angina y con una vida completamente normal. Otro caso, este era un poquito para enseñar que no siempre los pacientes que nos dicen que tienen necrosis, que no hay isquemia, pero si están muy sintomáticos, pues a pesar de que las pruebas no invasivas nos digan que no, pues habrá que darle un intento. Otro paciente, 71 años, hipertenso, dislipémico, con un ulcus gástrico furculado y también con una cardiopatía isquémica crónica, con una fracción de eyección del 40 por una cinesia anterolateral e inferior. En el 2010 se le hizo un cateterismo, que ya enseña enfermedad de 3 vasos, y se trató 2 marginales y tenía una oclusión crónica de la derecha que no se trató. En el 2018 un SPEC nos enseñó necrosis inferior transmural con isquemia mínima preevasional y la necrosis infralateral también, y no transmural apical. Y en el 2019 se repite el cateterismo, se vio que los stents de la derecha están bien, hay de las marginales están bien, pero que tiene la oclusión de la derecha. Y nos piden que la intentemos. Este es el caso, una coronaria derecha ocluida desde el segmento medio, con un vaso distal que es, aquí veremos que básicamente es una interventricular pequeña y con enfermedad difusa. Este es un paciente que nos habían remitido desde otro centro para que lo hiciéramos, y cuando estábamos ya metidos en el caso vimos el vaso que nos estaban pidiendo que abriéramos, ya esta interventricular posterior, porque era una codominancia con una circunfleja muy grande. Hicimos un intento anterógrado con guías, llegando a la zona de la interventricular posterior, pero sin conseguir conectar, siempre por falsa luz. Decidimos hacer un intento retrógrado, que no sé si no se ha visto, pero hicimos también un intento retrógrado sin conseguir ir, y al final abandonamos porque era un vaso que realmente era mucho esfuerzo para intentar recuperar un vaso muy pequeño. Y ya el último caso que quería enseñar es un 70 años, hipertenso, con vasculopatía cerebral, con una SEA también anticoagulada y una cardiopatía isquémica y valvular, que también en el 2007 para estudio de prequirúrgico de vascular se hizo un cateterismo que me enseñó una enfermedad de la derecha ocluida y una lesión en la área moderada. En el 2014 empezó con angina y ya se vio que tenía una función deprimida, una insuficiencia aórtica moderada severa, una quinesia inferior, la oclusión de la derecha y una lesión severa en la DEA, que se trató. Dado que tenía una aorta en porcelana, se rechazó para la cirugía y se hizo tratamiento de percutáneo de la descendente anterior. Y luego se remitió a nuestro centro para valoración de la TAVI, porque el señor tenía la insuficiencia aórtica y seguía con disnea y angina. Se le hizo una ecografía en nuestro centro que decía que la insuficiencia aórtica era moderada y se le hizo, y que tenía la quinesia inferior, y se hizo una resonancia que hablaba de necrosis transmural inferior. Por lo tanto, ni se le puso la TAVI inicialmente ni se le revascularizó. En 2018 seguía con un Angor de pequeños esfuerzos y disnea, y se nos comentó para ver si podíamos abrir la coronaria derecha, a pesar de que hablaba de necrosis transmural inferior, porque seguían diciendo que la insuficiencia aórtica era moderada y que además era pura y para TAVI tampoco era óptima. Pues hicimos el cateterismo, los stents de la descendente anterior estaban bien y teníamos una coronaria derecha con oclusión corta pero muy calcificada, que con facilidad cruzamos a base distal. Se predilató con balones, luego con un cutting y se pusieron 2 stents que se posdilataron. El resultado final es óptimo, un caso bastante sencillo esta vez. Y la evolución del señor, pues que a los 12 meses está sin angina, sin disnea, y sigue con la disfunción ventricular y con una insuficiencia aórtica que sigue siendo moderada, pero el señor clínicamente ha mejorado mucho y ahora ya puede salir a pasear y a caminar sin angina. Pues como conclusiones, ¿cuándo no hay que tratar un iCTO? Pues siempre en los pacientes si están asintomáticos, si no hay viabilidad, si el territorio es pequeño, un pobre vaso distal, pero hay que individualizar cada caso porque no siempre lo que nos dicen las pruebas no invasivas es concluyente. Y como última conclusión, que necesitamos más evidencia y no evidencia para acabar de decidir cuándo tratar y no tratar una oclusión. Muchas gracias.
I think that in Valladolid they made some progress. Ignacio?
Dr. Rumoroso.
Yes.
Yes, I want to show you at which point we are now. This is, I think, where we left. This is the judo 6 crossing. Seen in the true lumen, it goes to the septal. This is the corsair that could not close, although we were able to advance a little bit more than with the Mamba. And so this here is that we removed our wire because the corsair was, you see, more advanced in the plaque. We removed the judo 6. We did a bet. We remove it and we advance the rota wire. The rota wire is in place. This is with the rota wire in place, and this is the Dynaglide. We are advancing 1.25 olive, and this is just Dynaglide. So, and now is the rota. You can see the first attempt. Really, the speed decreased very quickly. It was stuck there. Could not cross. We just improve a little bit the support with the catheter. And here is the second attempt. And this was a tougher place, and now we were able. I went maybe a little bit far, but I saw some calcium down there. And this is the angio afterwards. No, this is the Dynaglide for removing the olive. You will see now the olive in your left. So we could remove it doing Dynaglide very quickly, very comfortable. And this is the angio. So we still cannot see anything of the vessel. It's probably there is competitive ipsilateral collaterals. And we are at the point where we have replaced our wire. This is the Mamba flex that crossed very easily after the rotablation. We changed our wire for a mailman wire. Mailman wire is an extra support wire. And we are at this point. You can see the trapper because we have just removed the catheter. And now we are planning to do some IVUS.
Okay. Did you experience any difficulty in going with the rota wire? Did you have any?
Yeah, I was a bit afraid. I really, but I thought if I remove the judo and I cannot advance the rota wire, probably I can advance again easily the judo. But I think I stored the advancement of the wire. No, I was sorry. I did not store this image, but it went through very, very easily. I think the worst part of the plaque is the distal bending of the microcatheter there. So this was the critical point, and the rota wire crossed very, very easily.
Okay. Sometimes you can improve a lot the sliding properties of the rota wire, just wetting the coil with propofol at the tip. In that maneuver, you can. It helps a lot to cross where at the same place where the wire went initially. So another interesting issue that you commented is the how simplistic we are using the rota every day with going up and down with the Dynaglide, moving it over the guiding catheter. It simplifies a lot the way of doing even just only with one operator, the way of doing a rotablator. I don't know if you use this technique.
You can see now that we cannot cross with the IVUS. I will show you. This is live. I try to cross, but now it's crossing. No. So, but since I'm there, I'm going to check the left main, okay? And then we will predilate and cross with the IVUS again. Can you show the IVUS big? When you can see, tell me, Dr. Moroso, and I start the pullback.
Okay. We will wait to see the pullback.
Yeah.
Can you already see the IBUS?
Wouldn't you like to go with the bigger olive? Because you can have issues not only crossing balloon, but also expanding not only balloons, but stents. So if you go with a bigger olive, maybe it will be easy then to have a good expansion of the stents.
This is live. This is the pullback, and we are in proximal LAD. I will pull back my catheter a bit to check correctly the left main. So there is huge load of atherosclerotic plaque. Maybe you can comment if you.
Yeah, there is a huge calcification, nearly 270 degrees. I suppose that is the left main now.
It's a big vessel.
Big vessel.
It's a huge
calcification. Yeah.
It's with a very good area.
Okay, and I'm going out to the aorta, so we can measure the minimal lumen area.
Yeah, there's an eccentric plaque there.
Y el balón, ¿vale? Okay, we are going to measure the IBUS, the minimal lumen area, so you can see.
Yeah.
Please, David.
Yeah, fish. Yes, that's okay.
Balón te lo paso, si quieres.
Vale. Igual hay que usar algún balón de corte. Podríamos buscar un angiosculpt de... Uy, espera, un Wolverine de 2.15 o algo así. Sujétame la guía.
Probably the tight lesion, it was in the ostium of the LED.
Yeah.
Don't you think so?
Yeah. Yeah, I see. Tengo guía.
Yeah, but it looks like more. Yeah.
El IBUS lo llevo yo, lo llevo tú. No.
The main problem here is that when you have such a diffuse disease at the proximal segments of the main vessels, an intermediate lesion at the left main, if you want to treat and leave it perfectly well, the left main should have to be treated.
Yes, but probably he has a proximal landing zone with calcium, but with a good lumen in the proximal segment of the LED, and probably you don't have to treat all the LED till the ostium, no?
Yeah, I'm also thinking about the circumflex and the intermediate ramus also.
That's right. You have a severe lesion in the ramus.
Yeah.
And are you for the member of the panel, are you comfortable using rotablator in total occlusion when you are not sure exactly if you are in the true lumen or you are crossing subintimal? Yeah. Or do you prefer another technique like laser or whatever?
If you are confident with it, it's not a problem. It's not a big problem. You can also use some IVL in these cases to modification the plaque and to broken the calcium. And sometimes we did some cases with the IVL to change the ambiguity of the proximal cap and create space for to go into the subintimal space.
Yeah, in my opinion, regarding what you said, Antonio, I would say that it is even safer to do rotablator rather than to dilate with balloons undilatable plaques, because the possibility of having a vessel rupture is even bigger. You do not control what you are doing with the calcium And the rotablator, even if you have a sub-intimal space already passed through with the wire, nothing is going to happen, because you are going to ablate the calcium ring. So in my opinion, it's even safer. So just a little comment, Dr. Amat, and we will leave you working. We will come back again to the discussion of Bernat lecture.
Yes, you see, we have dilated with the emerged balloon. I think it worked pretty well. Still, there is a place close to the diagonal that was tough to cross. I'm going to use the wedge balloon. It's a cutting balloon with one filament of cutting, so the profile is quite good. Let's dilate, and then I will do new IVUS, and we start deciding our stenting. Probably we will stent the diagonal first, and I'm considering the ramus intermedius or marginal for the left main. Yes?
Can you hear me? At this point, how can you improve your support? If you are going to treat the diagonal, you can do anchoring balloon in diagonal, and you can work very well. I think it's a possibility.
With what? How can I increase my
anchoring balloon in the diagonal? If you are going to to finish the bifurcation LAD diagonal, we can use anchoring balloon in diagonal. You can have more support in the ostial left main, and you can manage all of the devices in the LAD, because you need to do hard work in the LAD to leave the very good angiographic result, and probably you need to do IVUS for to guiding the stent implantation, what is the landing zone, what is the sizing, it is the quality of your stent implantation. It's very important.
Suggestion. So we are going to treat for the diagonal, and we will use it as support for advancing our stents.
If you are going to treat the diagonal, you can use anchoring balloon in diagonal, and can help you a lot.
For sure. Thank you. Thank you for the suggestion.
Yeah, it's going to be a very interesting case, because we will have at least 2 bifurcation. We have calcium. I mean, this is a cheap case, so we will have time even to discuss later on. So, coming back to Bernat lecture about when not to treat the CTO, which is maybe the most important thing. How can we assess how symptomatic is the patient? Because, or the question is just asking if the patient has got angina, pain, is just enough to assess the functional situation that the patient has? This is a question for all the panelists, or should we have to do something else? Also, Pablo Salinas should have to ask, which is somewhere there. Bernat?
Well, it's Pablo.
Anyone of you.
I was going to suggest that the issue you raised is very interesting, because we are now told that symptoms, but symptoms are not very easy. We all know that when we ask a 72-year-old lady with some articular, maybe knee pain and overweight. So I think we have to move to more specific tools, and some of those tools are artificial intelligence. There are a couple of trials very interesting using a machine that will study the patient answers to a specific set of questions, and it's been proven to have a good correlation with functional capacity. And another more terminal maybe thing is exercise capacity. So maybe ergospirometry could have some position there. And there are a couple of trials assessing VO2 max pre and post CTO, and you can improve exercise capacity. I don't know if in any of our centers participating in the trial they are doing ergo spirometry, but I think it's an interesting thing that we could be seeing more and more in the future.
Mm-hmm. Yeah. Any answer from the panelists? I think that this is really very important, because we just only ask the patient how about pain, but in the few trials that we have, at least we always see that we look for quality of life. There are some papers published already with BO to consumption. We usually do all the patients before and after, and let's see if in a long time and long period that we are doing, we will have some results about which patient could benefit more. But I think that I agree with you. I think that we have more tools today to study better the functional analysis and capacity of these patients. The discussion is open. Also, another interesting thing is how we look for ischemia. What do we do? Should we have to do a stress echo, just only MRI with drugs or SPECT or what? And how to look for viability? How should we have to do it?
Those are difficult questions.
Yeah, but those questions we have to, if we have to have a clear protocol, a clear way of studying these patients, because when you go to the papers on how those patients are studied and how they go to the cath lab, we usually in CTO expert centers, those patients are much more studied than even a patient that just only has angina and goes to the cath lab, maybe sometimes without even an ischemic test to prove that he has something. So we usually study very well the patients, but is expecting enough? Stress echo, MRI, what should we have to do?
I think, Jose Ramon, that sorry, go on.
Yeah, Pablo.
It's okay. No, it's okay.
I just was going to say that we have to really be honest, and I think we are not very good at assessing symptoms, at least not to quantify symptoms. We can make some quality assessment, but not quantify. So we need whether scores or more functional things like 6 minutes wall test or ergo spirometry. But I think just talking to a patient and taking him to the cath lab or from the cath lab, not doing the CTO, is very difficult. So I think whether with artificial intelligence or systematic assessments, we need to improve on that field a lot.
Okay, Pedro?
No, I was saying that the assessment of symptoms is very difficult. I'm not sure if the VO2 max will bring us some more help, but I don't know if it will be enough. And this is true not only for CTOs, but only for patients with non-occlusive lesions. It's the same, because some patients, you should treat them if they have symptoms, and you don't know really if the symptoms are related to the cardiac disease. When you talk about CTOs, well, it's a question of debate. But I think that viability is most important because besides symptoms, it's not so important to assess ischemia, but at least to my opinion, more viability. Because if you have viability in a CTO, the probability of not having ischemia is very, very low. And regarding viability, you have magnetic, you have RMI, which it's a good tool to assess viability. Regarding ischemia, I must tell you that it's very difficult because we can't trust neither RMI, stress echo. It depends a lot on the operator. And regarding thallium scan, we have a lot of false negatives and false positives, so it's hard to trust. So I think we don't have yet a good ischemia, a good test, a good exam to be sure if there is ischemia or not.
Okay, we have a question from Mexico also. I don't know if you want to answer, Bernat, but it's open to anyone. What's your opinion about the consistent CTO trial? And also, there's another question about the possibility of sending the patients to surgery because of the great number of devices that we usually use and the cost of the devices and the procedures and the need of revascularization. So, anyone would like to answer? I think that the consistent CTO trial is not already published. It was presented in the EuroPCR, but not sure if it was published. Bernat, would you like to answer?
Well, from the consistency of the trials, I think we need more evidence. Now we haven't evidence to assess that the treating the CTO we improve the prognosis of the patients, but I think it's difficult to assess that. And for the send the patient to a surgery, well, it depends of the anatomy of the patient. It's only one vessel disease. It's sent to the surgery for one vessel disease. It's in the actual epoch, it's difficult for me. I think it's better CI. But it depends. We have 3 vessel disease and dysfunction and diabetic. You can send.
Yeah, because sometimes many of the CTOs, if you have the expertise, it's just only cross with one wire, no? I mean, and there's it's even easier than a very complex CTO, non-CTO PCI, no? Like what you find after opening the CTO in Dr. Amat's case. So if you agree, we are near to 12 o'clock, and it could be a good moment to go to Hospital Puerta de Hierro to see how Javier and José Antonio are going with the case.
Can you see it?
Yeah.
So we've gone down anterogradely, not with some toil, to the posterolateral. We tried to engage with a second wire the posterior descending artery. So what we did was to try to progress with Sasuke double lumen catheter in order to put the second wire in the posterior descending artery, and we did not manage. So what we've done is to balloon the whole section with a new balloon that Jose Antonio will tell me the name.
Alveo.
Alveo. 0.75 5 millimeters.
Can you show all the steps because we are just only seeing the screen, but
yeah, sure.
Okay, so yes, we'll show you the.
Tenemos que irnos a principio de.
I'll show you from the start. I'm sorry for.
¿Qué?
El balón anterior lo.
Se ha roto. No, lo tengo aquí. Ahora lo retiro. So we have made a wire escalation and desescalation because we started with a fighter, as you know, but we didn't cross the proximal cap. So we tried with a Judo 6 that was able to cross the proximal cap. But at this point, as you see in the tip of the microcatheter, it was in the angio. If you remember, there was a messy segment there. So we decided, Javier and me, to move to a fighter again, and the fighter could cross just to the cross. But unfortunately, we were in a false lumen. So we have to change the fighter. And now we are going to show you. This is the fighter. It was a false lumen.
We also, excuse me, we also changed it. This is a vital point. We changed the microcatheter. The Mamba Flex would not go further. So we put a short Corsair Pro. We took out the fighter wire. This is the point where we were. So we had the bifurcation just in front of us, and it's an ideal situation for a Gaia wire. And this we did with not a lot of difficulty, I can tell you. And we went to the posterolateral and said, well, okay, then we won't worry, we'll pass a double lumen catheter, which we were not successful because of the tight stenosis, tight CTO. This is the next step. We went with the Corsair Pro distally. We exchanged the Gaia for a Scion Blue.
Extra support, Scion Blue extra support. Yeah.
Which is this one. We tried to go in with the Sasuke unsuccessfully, and what we did was use the 0.75 balloon, and this is the technique of pinching and going forward step by step, step by step, step by step. And now we are at this point. We do not want to inject anterograde contrast. We're going to keep on ballooning and then maybe try to wire the posterior descending artery and finish with a bifurcation. Is that, I don't know if there are any questions.
Voy a retirar el balón este.
Sí.
Did you do any injection to see the relationship with the bifurcation?
We did a Jose Ramon, we did a contralateral injection to test we were in the correct lumen.
Okay. Uno más de Fenta.
Now we have to go, I'm sorry, but we have to go a little bit fast because the patient is not comfortable. I'll help you.
Okay, so, I think that it's really interesting and a very good work the way you step up and step down the wires to get distally to the PL. So maybe we can leave you here.
Okay.
Stay okay. Work there with the patient, and we will not disturb you. So we can change to Hospital Clínico Valladolid, and after you can tell us.
For not paying attention.
We will leave you, okay?
Sorry, José Ramón.
Can you hear me, Dr. Rumoroso?
Yes,
Vale, venga.
yes.
Pilar, habla con el paciente. Explícale que estamos...
So this is the where we stopped. We have not advanced much because it was quite tough dilating the diagonal indeed. So we have been working on that, could not cross, tried with the stent, after dilation could not cross, and we have to dilate several times. Sorry. So, and this is after stenting, we adjusted in a caudal view. You can see a small bubble in the catheter, but I think we avoid it. The patient is stable. Indeed, he's having high pressure. And now we have advanced our emerge. This is live. The emerge in the diagonal to use it as anchoring, as suggested, I think, by Dr. Silveira. And we are going to advance the stent in the LAD. So this is where we are now. Okay.
Nacho, did you any IBUS to the LED to know exactly from where to where to implant the stent?
Good question. We were just discussing this when we reconnected. The thing is that we want to keep some distal vessel in case one day there is restenosis or something. You see the diagonal that we have stented, and then there is a small diagonal more distally, very small diagonal. Yeah. I think we need to go almost there. What do you think?
Yeah, watching the angiogram, I think that yes, no? But probably it would be very useful to do an IBUS.
Yeah, I think that you have such a good enough landing zone there, proximal to the radiopaque part of the wire in the LAD, and go from there to more proximal. So there are always doubts about where to go from to in this diffuse disease, because all the arteries is a plague from the beginning to the end. But the good thing you mentioned about restenosis, I think that the good thing that the consistent trial show us is that the results with this new generation DS are good enough to do not have the restenosis we used to have some time ago. I think that also, Pablo, you participated in a study looking for all the events of drug-eluting stents in terms of restenosis, thrombosis, and events that you published in the JAC paper.
Regarding the anchoring, and we are having some difficulties. It's not that I'm ignoring you, Antonio. I heard about the IBUS. The thing is that we need to move a little bit quick because the patient is okay, but is having some chest pain. So I really want to stent. I'm going to be conservative, so stenting as proximal as possible. And when he's stable, we might do IBUS distally to see if we need to stent more distally. Okay?
Si hay que hacer otro, luego yo me quedo. Me puedo quedar.
Bueno, a ver si which size of the stenting are you going to use? Ignacio, can you hear me? Which size of stent? The size of the stent?
The stent that was implanted in the diagonal was 2.5 26 millimeters. Now I have a 2 millimeter balloon for the anchoring, and the stent that I'm advancing now is a 2.5 38. The longest stents that we have here are 48. See, it could be an option. It's a synergy stent, but here we are advancing the Elunir stent. Okay, it's been okay. This has crossed. Okay, It was tough. I have tried, I could not cross, but with the anchoring a little bit more proximal, I was able to cross.
I think it went really well with the anchoring, with no problem.
Vale, implanta A12. One inflator. So I have to change with the anchoring and the stent. So we don't forget that we have the anchoring and we don't extend the balloon. We don't trap the balloon in the branch. Fuera.
That could be a really great problem if you do it.
So if you see that we are going to do it, please tell us.
Yeah.
Vale, vamos a dilate rayado. Balloon just to predilate. And I maintain still the anchoring balloon there. Fuera. Vale, y ahora vamos con el unir de 275-38, ¿vale? Recuérdame que retire el balón de anchoring.
Well, this is a good example to see that anchoring is feasible with 7 French guiding catheter. And it helps a lot. Really, anchoring techniques are very useful. We could see also in a case presented by Bernat.
Excuse me.
He also had an anchoring.
Came back to IVUS. How is the MLA of the proximal LAD?
I think it was 4 point something at the ostium, wasn't it?
No, the proximal LAD.
Yeah.
Are you going to implant a 265? Why don't you implant a 3 or 3.5? Because it's a big vessel, okay? You have
no, but that was in the diagonal, Joao.
I know, but it's in the distal LAD is 2.5, and he is going to implant a 275 in the proximal LAD.
I'm not sure about that. He will tell us.
Morrison?
Yeah. Joao is asking about the size of the stent in the proximal LAD. Regarding the
it's okay.
Yes, I have not stented the proximal LAD yet.
Okay.
And I have taken a 2.75.
Okay.
Based on the IVUS that we did before, and probably I'll have to post-dilate. This was the Lunir stent that initially could not cross, but now with the anchoring.
Don't forget to take off the balloon in the diagonal.
Yeah, we are forgetting this. Thank you very much.
Okay. Keep it simple, keep it safe.
Just for the show, we won't do something like that. Ok, bueno, esto es un poquito lío aquí. Okay, so this emerged balloon has had like 30 inflations, I have to say. Well, good job. Now we have to adjust, I think, in a caudal view. Let me see where was the distal stent. Well, here we can see it. Let's go to distal. So we have a long overlap segment, but we have to pull back. No, not this. Vale. Un test de izquierda, por favor. Okay, I'm too proximal. Vamos a hacer un cine aquí. Adelante. No, I'm too distal. Okay. This is what to do, right? I think I'm going to come very proximal.
Yeah.
To the ostium. I'm going to try to adjust to the ostium.
Sure.
Yes.
What about putting a wire in the intermediate?
I don't think I can advance it easily with the stent and the 2 wires, so I want to move on. Test. But it's a very good tip that we should have done before. So, implanta. I'm trying not to cover it. 14. It's just the condition, the patient is okay, but you know, it's something can happen. So I'm trying to move a little bit quicker. Fuera. We did check with echo, everything is okay, but it's just, remember that it's 3-vessel disease. So there is diffuse ischemia here. Every little pain, chest pain, things like that, we have to pay a huge attention to this because things can happen. We can do a stem bush here to see if we have overlap properly, but before I'm going to post-dilate the overlap, 14. This is the same balloon of the lunar stent. Okay, fuera.
It's very tricky because you want to have some stent in the proximal LAD to do the pot with the diagonal, but then you will have problems. Maybe, I hope not, with the ostial LAD. Very tricky, very complicated.
Boost unintentionally. I think we need to post-dilate the overlap.
At least all the branches are open, but although all the things that you...
otra vez, Jesús.
Joao?
Are you going to intend to do IVUS or not?
Yes.
Okay.
Let me remove the wire from the diagonal and place it in the marginal, and then we will do the IVUS, okay?
Yeah, this is the learning point of view. It's very interesting if you can do IVUS for the quality of stent implantation.
Okay, so, this shouldn't happen, okay. Okay, the wire is moving out quite easily. Let me see if I can use the same wire for the... ¿Un test, por favor? Creo que aquí voy a necesitar aguja y rotor.
¿En cuál estás?
Voy a ver qué tal está el señor. Si todo está bien. ¿Dónde está? So, yes, I think IVUS is really important to optimize the result. Here it seems more or less okay, but we might have some really under expansion of the stent that might condition the long-term outcomes of this patient. And we are doing this as an alternative to a mammary artery. So the long-term outcomes is really, really important in this case. Always, but especially when you are competing with good surgery.
Yeah. If you want to be competitive with surgery, you need to be technically perfect.
So now you can see the issue we have with the catheter. It was like that from the beginning.
Il faut toujours choisir les bons cathéters. C'est pas les bons cathéters.
I think I'm going to let my colleague Alfredo Redondo do this part because I did the fun part.
At the end, nice, not so nice.
I think I need to change this wire. It's a little bit damaged.
Probably.
Samurai RC, por favor.
Maybe you could tell us. Maybe you could tell us the amount of contrast that you have used, and also how many frames are you working with, and also the radiation dose that you have up to this time.
So we work with 7 French because we were sure that we were not doing crossbows or stingray because we don't want to damage the distal vessel. So it was true to true lumen or nothing. That was the option in this patient. This is why we chose 7 French. If not, we should have gone with 8 French for sure. Radiation is 2.6 grays and a contrast 340, I think. Right?
Yeah. Okay.
Yeah. So still we have some work.
I would like to say something at the end. At the end, the stent it was implanted proximally where you thought you were going to implant it, Nacho. And despite of that, the distal vessel looks like very nice. So
it's good.
Probably a stent implanted till the just apical part of the LED, it wasn't necessary, you know.
It's IBUS and we see it, Antonio. Okay, let's see if the landing zone of the stent was okay, or now we have protected this branch. I don't know what sedation you use. We have administered a little bit of midazolam and fentanyl, and in the beginning the patient tolerated very well the procedure, but now he's starting to get tired. We don't go on to administer much more sedation. We don't have an anesthesiologist in the lab for these cases, or for any. So what do you do in this regard? Because now it's an important issue for us. I'm getting nervous because of that.
We work with anesthesia all the time.
We do not use also anesthesia for these cases. Let's say never. If we have to administer something like midazolam or
El señor, que no sé qué le pasa.
we do it ourselves. So I think that in most of the places, the cases are done without anesthesia.
We the same. We don't use anesthesiology. And we use midazolam and fentanyl. That's what we use, just only, you know. It would be nice. Why not to have anesthesiology?
I was live, and if you can see also the angio, I'm right there, just distal to the stent. Okay. So I'm going to start the pullback.
Okay. Can you, José Antonio, put the image in a greater
2000 más.
Can you zoom
size?
Can you zoom the live?
Well, if you cannot see it, I'm seeing the distal vessel. There is some plaque from 12 to 6.
We can see. Not very well, but
now it's better.
Like our Japanese colleagues say, this is there was a plaque in the distal vessel that we will show you later, but it seems like, and now we are in the stent, but like 5 to 10 millimeters beyond the stent, there is a stenosis. We will show you later. You can see in the longitudinal view. You can see the stent and the stenosis there with calcium.
That's good.
Have you seen a healthy vessel distal to that plaque, Ancho?
If I have feel what?
If have you seen healthy vessel distal to that plaque?
Yes. If you see the longitudinal view, in the longitudinal view, you can see that there is calcium, but the size of the vessel is okay. So half circumference was calcified, but in this point, just beyond the stent, it was circumferential, and it was, I think, significant, and probably we need to stent also that, which is not easy, because even for advancing the IBUS, I have some difficulties in the proximal LAD. So I hope the stent will cross easily. So I think we are now proximal. Now we are in the proximal stent. Is this we can see the struts, not very well, but I think. Huh?
Not very well. Where are you?
We have a gap there, maybe.
You have a gap.
Yeah.
This is a missing. You have a missing area.
Yeah. Okay, and I'm very interested in the ostium now. We have already done 77 millimeters, so I hope we have length enough. Which is the length of the IBUS that we have, David? How long is the pullback?
100.
100, 100, 100. Okay. So we still have 10 millimeters, and this is the ostial part. We have 7 millimeters to go.
Okay, you can go post dilating. 3 or 2.5, huh? It's a big, huge vessel.
You see, if the result is good, but we have this, okay, and this is the ostium. So we have, no, sorry, this is the distal part.
Yeah.
Okay, and I'm going to remove manually so we can see better the ostium. Can we see live? Thank you. I'm pulling back manually. Oh, it stops. I think, okay, stop. Yes, stop. You see, so I'm recovered. You can see it. Okay. So I'm in the proximal part now. This is the stent. And now no more stent. This is the ostium. Okay, I think it's not significant. It's not beautiful, but I think we don't need to go more proximal. Then I pull back more. This is the left main.
That's right.
And the left main is okay. You want to see again the ostium? I advance
think that
again.
the angiographical image that you have is worse than the IVUS.
This was the last angio after stenting. No, I think it's coherent with the IVUS.
Yeah, now it's better. Yeah. Okay, maybe you could leave that.
Yes. So I'm going to.
No.
Yes.
Can we see the distal vessel, Nacho?
Yes. Can we see David run 2 and the distal part, please?
Yeah, I'm not very sure there if the plaque is broken there or what's.
But look, more. Look,
Can you put it bigger, please?
There.
Can you put it bigger?
Yes.
Yeah.
Now we are in the critical spot.
The problem over there is not that lesion; it's the distal vessel of that lesion. You know.
Yeah, the distal. Yeah.
Yeah. If it's worthy to implant the stent over there or not.
Yeah.
Can you show us the angio again to see the distal vessel?
Vale, cambiamos al angio, porfa.
Cranial view.
Okay, it's me.
Yeah.
Sorry. This was the proximal stent. This is the final angio. Sorry, it was a bit short. We can repeat it maybe to make sure. Vale, so can we repeat it here?
Yes.
Vale. So we have to treat the gap and this little curve distally. Okay, I think I can see the spot. Vale, 18 está bien.
Okay, what's your opinion, panelist? What do you think? Pablo?
For me, it looks nice because distally, I think you have a lot of disease, and probably you have the problem that. Well, I'm not sure in this injection, the stent finally very proximal, no, isn't it? Yeah, probably that plaque that is immediately distal to the stent. Probably you can implant the stent. You have a good distal vessel, but a very short stent.
Yeah.
I don't know what do you think about that.
Any concerns about the diagonal branch?
That's good.
Vale, conectamos. Voy a hacer un cine en vacío para posicionarme. Creo que estoy ahí, ¿no? Vale, implanta ahí a 12. Sí, ¿no? So, what we were discussing about letting some vessel for the sessions, forget it. ¿Cuánto estás? 14, fuera. Fuera. 16. So I'm going to do a stem boost in the gap now with this balloon, fuera, to make sure the length. Although we have the length in the IBUS.
You can accept the length by IBUS.
Yeah, we have measured it, and they measured 20 millimeters, but I think it's too much. I don't believe it very much.
No. 10, 12, something like that.
Okay.
In this case, we can see how important it is to see the stent in the angiogram, you know, because in the angiogram,
can you see the stem boost? Sorry.
No.
Can we show this screen?
Herramientas intervencionistas.
Because it's very interesting, the image. So the balloon was 18, and the gap in the stem boost seems like half of this balloon. So it's very short. It's like 10 millimeters. I will take
10, something like that.
I'm sorry, because I was wrong before when I thought that the stent was proximally. Probably I didn't plan the stent distally, you know.
Sorry, Antonio, what you said? I could not hear.
No, that in the angiogram we cannot see the stent properly, you know, and in the place where is the balloon right now is the gap, isn't it, Nacho?
More or less, because there are some shouting here that we already can see the stem boost. Sorry.
Yeah, before I told you that probably I implant the stent distally, but I'm not sure about that. You know, I think that the distal plaque, what you have distally is a very calcified, narrowing vessel, so probably I wouldn't implant a new stent distally, you know, just only the gap.
Yeah, I think also visualization with the calcium is not very clear. So you cannot see properly the stent. So here the IBUS is also very, very important. I think even in non-CTO cases, when you have a lot of calcium, it really changes your work plan having the IBUS.
Yeah, I would say that if you want to compete with the surgeons, we should optimize our result as much as we can. And calcium is a problem for us. For living perfect results. So I totally agree with all your comments about the use of IBUS in this type of cases. It gives you a lot of information. It also prevents from using too much contrast, that in cases like this one can be not very
You can go up because you have asymmetric expansion of the stent, of the balloon. Don't you think so?
Yeah, we could see from the distal to the proximal part several segments. Yeah.
Yeah, I think it's what do you think about the role of post-dilatation or stent optimization in this case, mainly in the proximal vessel?
Yeah, I think that the main issue is to have a good lumen area.
Yeah.
The only thing is that maybe you should have to use some type of plaque modification techniques to get a better expansion or concentric expansion.
It's too late, Giuseppe.
It's too late. Yeah.
That's Dr. Rumoroso, because we are now doing the plaque tone registry, where we are collecting cases of plaque modification with orthablation, laser, lithotripsy, or cuttings balloons in CTOs. So we have already collected more than 100 cases, and if any center has cases like that, I encourage them to participate in the Iberian registry.
Yeah,
this was an advertisement in the middle, sorry.
Yeah, no, that's a really good idea. Because we do not in many cases, but we have to do it from time to time, and maybe we should have to do more times than what we do. What about any comment about what Joao was saying now? Could have been of any use the possibility of doing lithotripsy here after the rotablator to get a better expansion of the stents?
No.
What's your opinion?
You have some concerns about the effect of the polymer of stents. Okay, you can have some thrombosis. I'm not feel comfortable with this type.
No, I say before. Sorry, Joe. Before implanting the stent.
Or you can use overin, or can use something hybrid strategy in this lesion preparation. Or OPN balloon. It's also very good, but to gain lumen.
Yeah.
But you could also have used a 1.75 olive, because I think you just used the one.
Now it's finished.
Yeah, bigger olive. Yeah, bar. Yeah. Okay. I think that we are on time. If you agree, we can go to the lecture of Pedro Cardoso in Lisbon, who is going to speak about CTO and prognosis. We were speaking from the very beginning about symptoms, about prognosis. There are some concerns about it. So please, Pedro, go on with your lecture. We will leave you, Ignacio, to treat the LAD and the intermediate ramus. You will be able to show it at the end.
Okay, so I'm going to talk a little bit about the prognosis, benefiting in CTO PCI, and in my presentation I will talk about the PCI for stable coronary artery disease in general, and then regarding CTOs, the trials that we've got, some observational data, and talking about some subgroups as well. Well, let's start with FAME2. As you know, there was a benefit regarding to PCI regarding compared to medical therapy, but the benefit there was a benefit regarding the primary endpoint, but this was driven mainly by urgent revasc with PCI. But when you look at the 2 years result, you can see that if you sorry. If you look at peri-procedural myocardial infarction, they were obviously much more frequent with PCI. And if you exclude that, you have a clear benefit regarding myocardial infarction and mortality in this those results at 2 years. And the same is true if you look at the 5-year results. So when you exclude the peri-procedural myocardial infarction, you have a clear benefit because the curves crosses, and the P value is not significant, but because of the peri-procedural myocardial infarction that happens in the first 7 days. And if you look at ischemia, the same happens. There is an analysis in a supplementary appendix where you can see the spontaneous myocardial infarction in ischemia, and you can see that the curve, it's much the same as you've got in FAME2. As you can see, when you exclude peri-procedural myocardial infarction, you have a benefit in FAME2 and in ischemia as well. And as you know, ischemia was considered a negative trial for PCI, but probably it's not like this. And as you know, peri-procedural myocardial infarction has not the same prognostic value as it happens in spontaneous myocardial infarction. It has an impact on prognosis, but not that much, and not so much as you have when you have a spontaneous myocardial infarction. So it's not the same. And the question is if we should not exclude peri-procedural myocardial infarction in this analysis. Now looking at the trials that we have regarding CTO, the recent trials, Decision CTO and the CTO trial. Well, those trials were small trials. Someone talked about these trials yet today. And I would like also to make some comments regarding the crossover in Decision CTO, which was already referred about today. There are some methodological problems as well. The assessment, the patients were randomized for this study before the non-CTO lesions were treated. So there were many patients with reversal disease, namely about 40% patients with LAD disease, about 40%, 46% with RCA disease, and less so with CIRC disease. And so, as these patients were randomized before those lesions were treated, this can have a confounding issue regarding the real effect of treating CTO PCI. EuroCTO, as you know, was a positive trial regarding the relief of angina and the increasing quality of life. And there was also a trend toward less events, although this was driven mainly by less need of revascularization. And we were talking about FFR, and what can we say? As you know, in the FAME trial, there is a continuum of benefit with the value of FFR. The lowest the FFR, the greatest the benefit of PCI. And as you know as well, the FFR assessed in a distal CTO, it's much lower than we used to see with non-CTO lesions. Beside that, FFR of donor arteries used to be lower than we should expect in the presence of some mild stenosis or some intermediate stenosis. And the same is true apparently with IFR. This is a case that we've done in our cath lab, where you can see, now in the next picture, you can see that there is a modest LAD disease. And I think this is the same slide. The operator decided to do FFR in this IFR, sorry, and as you can see, the IFR was 0.55, which is much lower than we would expect with this kind of disease in the LAD. So this means that when you have a total occlusion, you have ischemia with some lesions that should not be responsible for ischemia if the occlusion was not present. Now let's look at some observational data. As we saw yesterday. There are a lot of meta-analysis, and the question is that in meta-analysis there is support for prognosis benefit, namely in mortality with CTO, PCI, and namely we can see that the prognosis of a failed CTO, PCI is much worse than what happens with the success procedure. Another issue is the completeness of revascularization. This is analysis, a post hoc analysis of the syntax trial, where we can see that the incomplete revascularization is associated with a poor prognosis, and we know, and this was documented in this analysis, that CTOs are strongly associated with the incomplete revascularization in this trial. So this is what we can see here. The incomplete revascularization is strongly associated with worse prognosis, namely with cardiac death, as we can see here. So this is evaluated with the residual syntax score. Another question is if it's probably as it happens with lesions, with non-CTO lesions, probably it has not the same impact on prognosis if you treat an NLED or if you treat the right coronary artery, and there is some evidence that the best if you treat an LED, probably you change the prognosis, and this cannot happen mainly if you treat a circ. This is another study from Japan, and here there was some benefit treating LED and RCA, but not so in the circ. So probably this is what happens also in non-CTO lesions. Regarding patients with low ejection fraction, there seems to be, well, CTOs have clearly a detrimental effect on the prognosis of these patients, and a successful CTO, PCI in a CTO change the prognosis when you compare it with a failed PCI in this subset of patients. This is another study where you can see that the medical treatment group has clearly worse prognosis when you compare it with the patients who were submitted to REVASC. Also, in diabetes mellitus, there seems to be a prognosis benefit when you treat CTO regarding MACEs and cardiac death. The elderly seems to keep the benefit that we can see in younger patients. So in patients above 75 years of age, it seems that there is no loss of benefit by treating CTOs. Well, but why can't we have trials, randomized trials proving some benefit? Well, because as you know, the mortality from myocardial infarction is very low nowadays. You have on your right, you have the mortality in some countries in Europe, and the mortality is about 5, 6, 7%. So even with big trials, namely with medication, it's very difficult to prove a benefit in mortality as you have it in IMPROVE-IT or Fourier, which were very big trials. So it can be very difficult to prove mortality in trials testing PCI, and particularly in CTOs, it can be almost impossible to have randomized trials proving a benefit in mortality. So probably we will have to look for other points for. Has to take home messages. I would say that the prognosis benefit of revascularization of stable coronary disease is still under debate outside some groups. That contemporary trials have shown a constant benefit for revascularization, reducing the rate of future myocardial infarction or the need for revascularization. And also in the setting of lesions of non-STEMI lesions in patients with myocardial infarctions. But given the low mortality of myocardial infarction, it would be very difficult or even impossible to have a mortality benefit in a randomized trial. The same is true, and even worse for randomized trials looking for just for CTO patients. So probably we'll, as I said, we'll have to look not for mortality in these trials. Anyway, the observational data, the observational evidence supports the role for CTO PCI by reducing the rates of MACE in generally, and also in the elderly, the diabetic, and mainly in the reduced ejection fraction. Probably more if you treat LAD, maybe in RCA, and probably not so in CIRC. So thank you.
Thank you, Pedro. Okay, your topic was really difficult and interesting because the question here is, the debate is open, obviously. The question here is, what do we have to look for? Do we have to look for a better life, or for to live longer? Maybe this is not the we are not going to achieve to live longer with this, but better to live better. But it's I mean, maybe the target that we are looking for is not very well defined. This is my opinion. Something that you commented also, and Bernat also commented previously, was the incomplete revascularization of the patients, that there is always a clear benefit for a complete revascularization in terms of MACE in mid and long-term follow-up. And the very interesting thing that I also put on there, and you both commented, is that you do not assess a complete revascularization with surgery. When you look at the anatomy and you say, oh, this patient is suitable for complete revascularization by surgery, but the real situation is that when the patient comes back, the surgeons didn't revascularize all that should have to be done, and they did the revascularization with venous graft nearly to all the vessels, but the LAD with edema. And then this patient comes back with a number of grafts already closed, and then the progression in the native coronary artery is so big and so hard that you have to then show your skills to open what is closed with a problem for the patient. So I would like you. I want to put this on the table and let's discuss a little bit with all of you. What's your opinion? You're open and free to comment. Pedro?
Well, I agree with you. This case that Amat is doing, I was saying that probably it was a surgical case, because regarding diabetic patients with vessel disease, it's true that we didn't prove yet to be superior, not even equal to surgery. But we have the problem of first, sometimes they do not do complete revascularization. Surgeons don't, and it's quite often. So we have a problem with that. And even if they do, saphenous grafts are not good. And regarding this, there are some data already regarding hybrid revascularization, which is also probably a good option in some patients, because it's true that when you have diffuse disease in reality, the arterial graft is probably the best choice. And it's true that it has more costs, but probably for the patients it can be a good option. And we face every time this kind of problems. And if we work well, if we think by the book, we must send the patients to surgery, but we know that we feel that it's not always the best option when they come back for us. So I think the hybrid approach, we don't talk too much about that, but it can be a good solution with some patients.
I'm not sure what is the surgical patient. I'm not sure. First of all, I went to see the surgeon registry. We don't have the surgeon registry. And the most important, if you have the tools, you have the skills. If you have the tools, you have the skills, and we have used it properly, you can do a very, very good job. I have no doubt about that. Did you remember my slide regarding syntax trial?
Yeah.
Okay. 32% of the cases they are going to surgery. The surgery with the CTO, this is nothing. Why they don't graft the CTO? Because they don't have a negative remolding. They don't have the vessel. They don't have a target. Okay, I understand the cases, but why? This is the problem. And when you are talking about the interventional cardiology, 51% of the case, they don't touch in the CTO. Why? What is the barrier to do the CTO? This is most important. Keep in mind, more than 50% of these patients came back 6 months, 9 months with angina because they didn't have complete revascularization. This is the problem. This is not the problem. It is the surgical patient of the interventional patient. They don't do their job well. This is the most important.
Joao, and do not forget the occluded grafts.
This is another problem. But also, if you have a lesion more than 70%, at 1 year, 50 or more, these vessels are occluded. When you are send this patient for patient, the most important source of the CTOs for us is the surgery. Because the surgery, you are not, you don't have the backflow, you have accelerated sclerosis and also calcification. This is the worst scenario that we have. This is post-CABG patient or post-CABG failure. This is, we need to change our mind and to do our best and best. Because we have the tools. You need to do, if you need to learn, okay, you need to learn, but it's not surgical. It's not for PCI. We need to discuss what you can do for this patient. You can go Lima for this patient, okay, but it's a diffuse RCA. It's a diffuse circuit. Are you going to do this vessel like that? Why? Why are you going to send the patient for the LAD with 3.5 or 4 when you can implant a stent when the TLR or 1 year lead step 5%? You can do by PCI, not to send the patient.
I totally agree with sorry?
No, I was talking about diffuse disease in LAD.
I know, but
even if in a diabetes,
you won't know the surgeon that are going to operate your patient. If you are surgeon, I'm interventional cardiologist, you are good friends, you have a very good skills. Okay, I'm very, it's okay, it's okay, I'm safe. For me, it's, if you can have a very good result, I'm fine with it. Okay, no problem with that. But the majority of the case you have around 20-30% of the case, the failure in the early phases. It's just a technical problem of the surgical. The surgeon have a very, very long-standing learning curve. This is different for interventional cardiology. You need to change the chip in our mind.
But what I think that obviously, if you treat the LAD with a stent, as you were saying, there's no reason to send the patient for surgery. I'm talking about this diffuse disease in which if you put 1-2 stents and you keep an FFR very, very low.
Okay, you can evaluate this patient as a physiology. I'm not very, very fan of physiology. I'm very confident what I can do for my patient. What I can do if I can achieve the very, very good angiographic results, I'm very, very happy, and I will have a very good prognosis, long-term prognosis.
Well, now that you have mentioned physiology, I have a question because we saw it in some slides in the presentations. I have a question for Pablo, who I suppose is still there, because Pablo works in Hospital Clínico Madrid, who is a reference in physiology all over the world. And also Javier Escanet is principal investigator of the Syntax trial, Syntax 2. So when we have a multivessel disease, like in the case of Ignacio or some other cases, and you have a CTO, when should we have to do the pressure wear and the functional analysis of the other lesions? Before approaching the CTO to decide what to do, or after opening the CTO and then thinking about treating the other lesions? I don't know if Pablo is still there.
Okay.
What do you usually do if you do FFR? Joao is not very fan of physiology.
No.
I'm sure that you do when you have to.
Yeah, sure.
Bernat?
If I have a patient with a 52 years old, a severe lesion of ramus and the CTO of LAD, I will do the complete revascularization. I don't care about physiology.
Okay, Bernat, do you usually do pressure wear, multivessel disease? We cannot hear you, Bernat. open the micro?
I'm not very fan of the physiology too.
Okay.
But I do when I think it's important to do it.
Okay.
But not...
So maybe we can leave this discussion for some other session. I know that in Hospital Clínico Valladolid are ready to show us something. Can we connect with Dr. Amat? We can see you.
Hola.
Hello.
Hello. So we have already finished. We have decided to treat the left coronary and leave the right coronary artery, but our patient told us, no, I'm already here. I want everything repaired today. So we have already stented also the right coronary artery.
Okay.
This is how we stented the marginal. We did not do a complex bifurcation technique, I know, but we did not want to go into the left main. I think it was a safe way to do it. This is the final result in the left coronary.
I think that the result is fantastic.
Then the right coronary artery was also calcified. There are two stenoses, and then distally in the PL are some lesions that we did not want to treat. We have modified the plaque with a Wolverine balloon.
Which size?
3.0.
Okay.
And then for stenting, we have needed an extension catheter, an extension of the guiding catheter. And this is synergy stent, distally 3.5 and proximally 3.5 as well. And this is the final result. This is the job of my colleague Alfredo. So good job, Alfredo. That's all from here. And thank you very much.
I think the result is fantastic.
This is very good. This is very good.
Very nice.
Very good job in a difficult case. And we were discussing about complete revascularization. In the former lecture, Pedro Cardoso was speaking about CTO and prognosis, and I said that maybe we should not have to focus all our target in mortality, in looking mortality. But maybe to make the patients to live better without symptoms, with better quality of life. And the thing is that using this new generation stents, like the ones that you deploy there, the results in terms of restenosis and thrombosis in long-term follow-up is really very different to the ones that we used to use some time ago. I think it really changed the quality of life and MACE. At the end of the day, is MACE what we look for these patients, no?
Yeah, if you cannot walk because you have a problem in your knee, then you need your pain to be relieved. This is something that we really need to understand also in coronary disease. I know the results about the ischemia trial, etc., but quality of life in our patients is as important as prognosis in terms of survival from my point of view. So thank you very much for pointing this out, Dr. Rumoroso. So we are going to close here with ProgLight, and I will join you for the debate of the last talk.
Ignacio, can I have two comments? The first of all, it's a very good demonstration how to deal with the CTO cheap patient in COVID area. Okay, you did your job very well. Congratulations about that. This is a good point of view for the patient. By the other side, when you are comparing surgery with the PCI, you in the right, you did very interesting thing. You did the PCI properly. You did the lesion preparation. You did a very good sizing for the vessel, 3.5 in the distal RCA, and you did in 3.5 in the proximal RCA. You achieve a very good angiographic result. It probably it's the best for long-term prognosis for this patient. Is this a surgical patient? It is a question. Can I put to you? I don't have the answer, but you did a very nice job. Congratulations.
Thank you. Actually, we left this patient for the discussion of the heart team. But when we explained to him, this was yesterday indeed, when we explained to him that we were going to discuss with the surgeons because anatomically it was a surgical case, he really insisted on us, please, I prefer, can't you try to do something? So we discussed internally and we decided that, okay, we are going to try the LAD, which is the one that marks the prognosis. And if we cannot, then we stop and we go for surgery. But I can understand what the patient is asking for.
Yeah, but also, if after you perform IVUS in LAD, do you think it's a good target to implant the lima? The such classification of distal LAD? This is another question.
Yeah, we are not experts on that. We are not experts. We are experts in implanting stents, but not in the surgical technique. But this is a very important point. I know that when this is so calcified, our surgeons say, I have really problems. I have to corticize, I don't know the word, to decorticate the coronary. And this is a complex and challenging technique. And often there are some issues in the distal graft with the points that they are there. So thank you very much.
By angio, you could find a lot of classification in proximal and mid LAD, but in distal LAD, it's not possible to see this calcium. You have a lot of calcium. Sometimes you have sent this patient for surgery. You have problems because this is not a good target because you have a lot of classification, and the patient come back to do PCI. This is what we have to discuss. I think we don't have one treatment for the patient. We need to know which is the best treatment for our individual patient. If you are good, if you are confident with your work and your results, okay, you can do, no problem about that. Thank you very much for the case.
Thank you. Thank you.
Thank you.
Thank you. So we can go to the talk, maybe Dr. Moroso.
Okay, yes, we will change to the last lecture, which is going to be given by Antonio Gomez Menchero from Huelva about the new tools for CTOs.
Good afternoon. At the same, like my colleague Bernat Serra, I think I'm going to do it in Spanish because it's going to be easier for me and probably easier for Portuguese and people from South America to understand my Spanish, no? Don't you think so, Joe?
That's perfect. Spanish.
Okay, perfect. So, mi presentación es sobre nuevas herramientas, nuevas tecnologías en CTO. Y bueno, en principio, pues he creído que quizás hay nuevas cosas en cuanto a las guías, en cuanto a extensores de catéter, stents, microcatéter y algunos varios, ¿no?, que tenemos que vamos a ir comentando poco a poco. Vamos a empezar un poco con las guías. Bueno, yo creo que en los casos que hemos hecho ya se ha demostrado las virtudes de alguna de ellas. Yo creo que como una novedad nunca pensábamos que una guía de 0.35 nos iba a sorprender a estas alturas, ¿no? Pero parece ser que, bueno, que la nueva guía de Asahi, la Silverway, pues está sorprendiendo. Vamos a hablar de ella, de la Gladius y de la gama de guías judo, que yo creo que son las que a Boston realmente pues le hacían falta. En cuanto a la Silverway, pues es una guía regular, es 0.35, que se usa para intervencionismo cardiológico, neuroradiología, renal, periférico, lo podemos usar para todo. De 0.35 habitualmente tenemos dos tipos de guías, ¿no? Una Springwire, que es una guía habitualmente hidrofóbica, de PCFE, de acero inoxidable, que habitualmente tiene una mala maniobrabilidad, pero un gran soporte, ¿no?, por el core de acero inoxidable que tiene. Y por otro lado tenemos las guías poliméricas, ¿no?, como la guía Terumo, que son guías con un revestimiento hidrofílico, un núcleo de nitinol, que mantienen mejor la curva y que, por lo lubrificadas que están, pues navegan muchísimo mejor. Problemas de uno y de otro, pues de una de ellas, evidentemente, que no la podemos manejar bien y que muchas veces, aunque tenga buen soporte, no la podemos dirigir como queremos. Y la otra, que precisamente por lo hidrofílica que es, pues muchas veces nos puede provocar disecciones o podemos ir donde realmente no queremos y no la controlamos adecuadamente bien. La Silverway viene a parchear todas estas cosas. Es una guía con una estructura de doble coil, con el sistema AT1 de Asahi, con un recubrimiento que es híbrido, y esto la hace pues muy segura y muy manejable. ¿Qué es un recubrimiento híbrido? Pues significa que en la parte distal es un recubrimiento de silicona, tanto distal como proximal, lo cual la hace muy segura en la punta y a nivel proximal le da un control de torque muy interesante. Sin embargo, tiene 65 centímetros de un recubrimiento hidrofílico que hace que esté muy lubricada y con una navegabilidad muy buena y para darnos una capacidad de manejar los catéteres y subir los dispositivos de una forma interesante. Aquí veis la estructura del doble coil y después la bobina que tiene del sistema AD1 que hace que el control de torque de la guía pues, sea muy interesante. Por lo tanto, viene a suplir los defectos de las dos guías. Este tipo de guía híbrida pues, hace que la curva la retenga bastante bien, que sea muy buena para el manejo de los catéteres, el recubrimiento híbrido, el control de torque y la navegabilidad. Después, me parece interesante también hablar de las guías judo, pero antes un pequeño resumen de realmente qué le pedimos a una guía. Una guía, son importantes todas las partes, ¿no? La primera parte, evidentemente, es el material del núcleo de la guía, que habitualmente son de nitinol, de acero inoxidable, y bueno, dependiendo de una de ellas pues tiene unas características u otras. El diámetro del core, cuando es un diámetro muy grande, pues habitualmente lo que te da es un mayor control de torque, ¿no? Que aquellas que tienen un diámetro un poquito más pequeño. Y el perfil del núcleo de la misma manera igual. Cuando es un perfil un poquito más corto, las hacen un poquito más, son guías un poquito más blandas que se pueden preformar y manejar un poquito más que las otras. En cuanto a la punta, tenemos dos tipos de punta, como sabéis, el core tip, que es cuando el alma llega realmente hasta la punta, que la hace mucho más resistente, con más capacidad de penetración, o el ribbon shape, que realmente pues, son guías mucho más blandas, ¿no? Y en cuanto a, por otro lado, si tiene un recubrimiento, son coils en la punta, y en cuanto al recubrimiento hidrofílico o no hidrofílico. Y en las guías de oclusión, pues le pedimos un poder de penetración. ¿Y en qué? El poder de penetración de una guía, ¿en qué se basa? En dos cosas. Una, en el gramaje que tenga en la punta, y dos, en el área que tenga en la punta. A mucho mayor peso en punta y menos área, mucho mayor poder de penetración. Y Boston, digamos que en ese margen de ahí, pues tenía como un vacío, ¿no? Pasaba de las guías más blanditas, las Samurai, las Marvel, las Fighter, dando el salto realmente a las Hornet 14-10, ¿no? Y con la Judo, pues ha venido a cubrir realmente pues todo esta gama de guías. ¿Y qué la hace interesante? Pues es una guía con como veis, un diámetro de la punta muy fino, de 0,08 milímetros, que es taper, evidentemente, ahora vemos que la longitud de la zona taper de la guía es la mayor de la que hay en el mercado ahora mismo, con 6 centímetros. Es una guía de acero inoxidable, pero con como veis, con un recubrimiento hidrofílico, un spring coil con un recubrimiento hidrofílico y con un gramaje que va desde 1, 3 a 6 gramos. Y otra cosa interesante es la tecnología EMT, ¿no? ¿Qué es esto? Pues es que el coil que va en la punta de la guía, pues va completamente pegado al núcleo de la guía. Las otras guías tradicionales, tanto tipo Fielder, Gaia, pues tienen un espacio, ¿no? Entre ese coil y ese núcleo de la guía. Esta tecnología pues la hace mucho más manejable, mucho más flexible y bueno, pues nos da esa seguridad para poder progresar por el vaso con mayor tranquilidad para no salirnos del mismo. De tal manera que cuáles son las virtudes, ¿no? Es taper, con un grosor de punta muy finito. La zona taper es más larga que las demás, por lo tanto le da un mayor empuje. Es muy flexible lo que es la punta, y una punta que habitualmente viene recta y que la podemos deformar nosotros, incluso con muy poquito, con 0,7 milímetros. Es verdad que, que cuando tú quieres hacer una guía en la punta, deformar la punta de una forma muy específica o una deformación muy pequeñita, a veces es complejo, pero bueno, habitualmente los que hacemos CTO, la curva habitualmente nos gusta hacerla nosotros, y un recubrimiento hidrofílico. Esto, pues bueno, si la comparamos con otras guías, con sus competidoras, ¿no? Pues la verdad es que cuando la testamos, ¿no? En zonas muy tortuosas y para manejar por dentro de oclusiones donde tenemos mucho calcio y tejido fibrótico, pues la verdad que la capacidad de penetración que tiene es muy interesante. esto es lo que os comentaba sobre el tip shaping, ¿no? Las Gaia, que digamos que serían las guías con las cuales, pues, bueno, pues se podrían comparar, tiene ya una punta preformada de 1 milímetro que a veces pues está bien porque lo mantiene muy bien dentro de la oclusión para poder manejarla, pero a veces pues es demasiado grande y no nos permite navegar por la arteria adecuadamente. Otra guía interesante a comentar es la Gladius, la nueva guía de Asahi. Esto viene a cubrir la gama de guías de Asahi, pues, pues una guía semejante a la Pilot 200. Nosotros habitualmente no la usamos mucho, la Pilot 200, pero bueno, yo creo que es una guía que se usa bastante, ¿no? Y pues la Gladius viene a ser una guía muy parecida a esta, una guía straight, que no es taper, con un gramaje en la punta de 3 gramos, con una cubierta polimérica e hidrofílica y un alma pues de acero inoxidable. Igual que las Gaia, pues viene con una punta preformada ya y bueno, pues yo creo que es una guía que realmente pues nos puede aportar cosas interesantes. Pero a mí siempre que hablo de guías me gusta colocarlas un poco en dónde podrían estar, ¿no? Evidentemente siempre para empezar pues habría que plantearse pues, guías mucho más seguras como es unas guías spring coil con un bajo peso de punta, como son las sesion, o si queremos, porque habitualmente los microcanales no siempre se ven, pues las guías Fielder o la Fighter, ¿no? de Poston, que realmente es muy similar, ¿no? Y lo más importante es saber, pues si sabemos cuál es el trayecto del vaso, si estamos seguros realmente por dónde va el vaso. Si realmente sabemos cuál es el trayecto del vaso y sabemos por dónde tenemos que ir, pues nos podemos encontrar con un mullón muy duro y blando o algo más taper. Si es muy duro, pues evidentemente tenemos que ir a guías con una alta penetración, alto peso en la punta, pero lo que tenemos que es pinchar. Ya hay, como sabéis, distintas escuelas, ¿no? De ir escalonando progresivamente o ir con guías realmente más duras directamente. Y si el shape es taper, es decir, puede haber un camino, pues entonces ya nos vamos a unas guías con menor peso en la punta, con mayor control de torque, flexibilidad y que tengamos una sensación táctil, evidentemente. Cuando vamos a guías altas, pues evidentemente tenemos desde las de Asahi Confianza 12, Hornet 14, Progress 200. De nosotros depende de la confianza o de la estrategia de cada uno de avanzar con guías de mucho más gramaje o ir con guías un poquito más con menos gramaje. Y si realmente pues tenemos la posibilidad, es algo más taper, pues lo suyo es ir avanzando con guías un poquito más suaves, desde las Gaias que tienen la punta microcónica, con el núcleo complejo, con la micro J, pues Progress, Miracle y las Judo, que ya las he explicado antes y no las voy a poder explicar. 2 escuelas habitualmente, nosotros somos más de step by step, de ir paso a paso, aumentando, pero bueno, hay quien realmente la testa inicialmente y coge una guía de mucho más alto gramaje. El problema es cuando realmente no sabemos muy bien cuál es el trayecto del vaso. En este momento es cuando tenemos que buscar guías pues, hidrofílicas, que sean un poco más seguras y que nos den esa sensación. Y aquí es donde entran quizás guías como la Pilot 200, que además nos permiten hacer pues el knuckle, que muchas veces nos saca del atolladero. Y en este caso, pues la Gladius, pues yo creo que es otra guía que realmente nos soluciona. Y si no, pues evidentemente pues tenemos la reentrada subintimal o el acceso retrógrado. En resumidas cuentas, esta diapositiva la verdad es que, bueno, resume muy bien todas las guías. Tenemos 2 tipos de guías, spring coils y poliméricas, straight y taper. Dentro de las spring coils y straight tenemos la de bajo gramaje, como son las Sesion, las de más gramajes, Miracle, 6, 4, 12 y las Progress. Y ya taper, pues entramos ya pues la Judo 1, que es donde la podemos encasillar, y con un gramaje un poquito más alto, pues las hidrofílicas. Tenemos las Ultimate Ebros, Confianza Pro y las Gaias, y las Judo 3 y 6, evidentemente, juntos con las Hornets, y aquellas hidrofóbicas, la Confianza Pro 9. Y en las poliméricas, pues la Taper tenemos la Fielder XT, y las que son straight, rectas, pues tenemos las que tienen menos gramaje, como la Pilot 50, pero cuando llevamos más arriba, aquí encasillamos a la Gladius y a la Pilot 150, a la Pilot 200. ¿Vale? En definitiva, pues cada uno nos sentimos cómodos con las guías que usamos, ¿no? Y yo creo que ahora mismo casi todas las casas tienen todo el abanico de guías para poder hacer la mayor parte de los casos. Después es las sensaciones y el tacto que cada uno tenga. En cuanto a los extensores de catéter, bueno, pues como inicialmente teníamos el guideliner prácticamente todos, pero sabéis que tenemos el Gaisila, Telescope y el Boosting, ¿no? Que es el nuevo extensor de catéter de World Medical, ¿no? Y yo creo que hacer mención realmente al TrapLiner, ¿no? Que yo creo que es interesante, lo hemos mencionado hoy, al final no se ha usado, hubiera sido una buena opción en el caso de Nacho, el ADA, cuando el soporte no era bueno y se estaba intercambiando además, pues varias veces de microcatéteres. Guideliner los conocéis todos, no vamos a insistir. El TrapLiner, ¿qué aporta? Pues aporta un guideliner y un balón para hacer trapping. Un balón que realmente está a 2 centímetros, muy cerquita de lo que es la entrada, ¿no? del guideliner, de la extensión. Y bueno, y como cosa interesante, pues el TrapLiner nos ofrece un diámetro interno mayor que las técnicas habituales o convencionales que usamos para hacer trapping, ¿no? Como es usar un balón normal o usar otros dispositivos de trapping. En cuanto al Gaisila, pues como interesante, tiene un hipotubo muy cortito que le da una transición. A mí me gusta, nosotros lo tenemos y lo usamos y la verdad es que nos va bastante bien. El collar helicoidal, que es radiopaco, que también es otra cosa que es interesante, cosa que, por ejemplo, pues el boosting pues no se ve igual de bien, pero la verdad es que este se ve bastante bien. El recubrimiento hidrofílico y después los tamaños hasta 8 frames. Otra cosa interesante es el mango ergonómico que tiene, que bueno, pues nos orienta muy bien cómo colocarlo. Realmente debemos colocarlo viendo nosotros lo que es la letra Z y el número, porque eso hace que la salida del dispositivo sea mucho más suave y que el dispositivo bueno, que navegue mucho mejor. Después, en cuanto al telescope, como interesante es la rampa polimérica que tiene en la salida. Fijaros que el hipotubo es mucho más corto en Gaisila, Guideliner, y el telescope la verdad es que lo tiene mucho más prolongado y eso hace que para avanzar el dispositivo la verdad es que sea muchísimo más suave. Y en cuanto al boosting, que es el nuevo de World Medical, nosotros la verdad es que lo hemos probado, nos ha ido bastante bien. Como interesante es muy flexible, yo creo que más flexible incluso que los demás, tiene un recubrimiento hidrofílico y es bastante duro, bastante steep y una punta muy atraumática, lo cual hace que disminuya el daño vascular y que se atrapen los dispositivos. ¿Esto a qué nos lleva? Pues que, bueno, que hagamos con mucho más tranquilidad pues el avance de los dispositivos hasta arterias, bueno, pues hasta segmentos mucho más distales, ¿vale? Bueno, pues nada más. En catéteres, pues tenemos muchísimos, ¿no? Yo creo que en estos casos que hemos visto hoy, la verdad es que tienes que pensar si quieres empuje o si quieres navegabilidad. Hoy en el caso que ha empezado Nacho esta mañana, por ejemplo, pues ha usado un Mamba inicialmente, quería un poquito un micro convencional, después pensó que podía necesitar un poquito más de navegabilidad y cogió un Mamba Flex, pero al final incluso se sugirió usar un Turnpike Gold, ¿no? Por Joao, ¿no? Porque, bueno, realmente lo que necesitamos es un poquito más de empuje. En este caso, como novedad, tienes que pensar qué es lo que quieres realmente. Como novedad, yo creo que es interesante hablar de los Mamba y del nuevo Asahi Corsair Pro XS. El Mamba, la verdad es que, bueno, es un catéter que tiene un perfil de cruce bastante bajo, mucho más bajo, evidentemente, el Mamba Flex, que es resistente, con coil, con la punta integrada y un recubrimiento hidrofílico y muy duradero. El Mamba Flex lo tenemos en 2 longitudes, pensado más para retrógrado y evidentemente pues para accesos de arterias epicárdicas que requieras un micro mucho más flexible y más suave. El 135 tiene 3 zonas de coil diferentes y el Mamba normal y el Mamba Flex tiene 5 zonas taper de coils que le da mucha más flexibilidad y manejabilidad, ¿vale? Aquí lo podéis ver, lo que son las 5 zonas. Tenemos una zona proximal que es bastante torqueable. Tenemos un recubrimiento interno que hace que la guía navegue muy bien y un recubrimiento hidrofílico externo. tenemos los taper coil y suele estar integrado en la punta, lo cual le da también mucho empuje y flexibilidad. En cuanto a la Sagi Corsair Pro, bueno, yo creo que a Sagi le faltaba un dispositivo como este, ¿no? La verdad es que quizás para la epicárdica que teníamos hoy, ¿no? Una epicárdica, pues, el Corsair Pro XS, que hace que tenga un perfil de entrada muchísimo más bajo y mucho más flexible en la punta, hubiera sido un buen elemento para poder abordarlo, ¿no? Yo creo que viene para competir con el Tumpike LP, ¿sabes? Como microcatéter un poquito más blandito, igual que bueno, con el Mambra Flex, pero con la capacidad de penetración por la torcabilidad. Como sabéis, pues tiene 14 guías que están enrolladas con un perfil, con una entrada de cruce a nivel distal, la verdad es que muy bueno, ¿vale? Y me parece muy interesante también lo que es el mango resistente al quincado, ¿no? Para facilitar lo que es la torsión sin que se quinque el microcatéter. Tiene un muy bajito perfil y la punta es muy suave y nos permite al final progresar, cuando lo comparamos con los competidores, casi un 43% más. En cuanto a los stent, bueno, pues yo creo que el Synergy Megatron, yo creo que es un stent que está diseñado precisamente para esto, ¿no? Para oclusiones crónicas, para lesiones arterias con muchísimo cárcel, con muchísima enfermedad y vasos grandes, ¿no? Troncos, bifurcaciones, que es lo que habitualmente hacemos con las oclusiones. Habitualmente, ¿por qué es así? Por un sistema de 12 picos que hace que tenga un mínimo prolapso del material, una mayor ganancia luminal y le da fuerza radial. Es cromoplatino, la verdad es que se ve muy bien en la angiografía. Hoy la verdad es que yo sigo pensando que un stent se vea la angiografía bien es muy útil, ¿no? Porque no siempre tenemos IBUS, ¿no? Y por otro lado, pues se optimiza el tamaño del strat para conseguir toda esta fuerza radial. Tiene 4 conectores habitualmente en las zonas más distales para que tenga más empuje y 3 conectores en las zonas más medias para mejorar también lo que es la fuerza radial. Aunque se optimiza el grosor y se aumenta un poquito, pero fijaros que está en un grosor de strat bastante bueno, ¿vale? Por otro lado, la verdad es que la expansión del stent, el aumentar el tamaño, el Synergy, pues hoy por hoy quizás el stent, como tenemos tamaños de 4,5-5, que puede llegar hasta 6 milímetros. Resolute Onyx, Sign, Sierra también lo tiene, pero la verdad es que esto es una buena ventaja para POT, optimización proximal y bifurcación. Por otro lado, el Biomind Morph me parece también otra cosa a mencionar en cuanto a las oclusiones crónicas. ¿Por qué? Porque nos permite un stem tape con distintos diámetros, distal y proximal, con distintos diseños de celdas, tanto en las partes más distales como en la zona media, para recruzar a nivel de bifurcación. Y, bueno, muy interesante también para mí que tengamos longitudes hasta de 60 milímetros. Lo cual, pues la oclusión es importante porque ya vemos que estentamos arterias pues casi de 100. Y el UNIR, que se ha usado en el caso de Nacho Amat en Valladolid, pues es un stent también prometedor, ¿no? Que tiene un diseño YSL, que con un strat ultra fino también, con una excelente conformabilidad que permite que la distribución de la droga pues sea bastante buena. Un recubrimiento elastomérico con una droga que es un limus, que mejora lo que es la distribución de la droga. Y muy interesante me parece lo que es el muelle distal que tiene, taper, que disminuye lo que es la fricción a la hora de navegar el stent. Y incluso además pues es radiopaco. Y después tiene estudios, la verdad es que en principio son alentadores comparados con Resolve. Fijaros aquí la punta, ¿no? Ese spring distal que tiene, como hace que la navegabilidad del stent pues sea bastante mayor. Y en cuanto a otras técnicas, pues bueno, pues la verdad es que hemos visto un rota en el caso de Nacho Amat. Yo creo que hay lesiones que son no cruzables o no dilatables y que tenemos que usar otra tecnología. La verdad es que el rota, pues sí estamos familiarizados con él, litotripsia, la verdad es que hay poco. Aquí siempre hay el miedo de ir subintimal, de estar muy seguro de por dónde se va. Y para ello, pues la verdad es que el láser es otra tecnología que yo creo que nos puede aportar, que empieza a tener evidencia en estos casos. ¿Por qué? Bueno, pues ya está, ¿no? Digamos, como segunda línea, pues al final, tanto la rotablación como el láser, pues pueden ser opciones. En el caso que hemos tenido hoy con Nacho Amat, la verdad es que al final se ha podido avanzar el microcatéter lo suficiente como para poder cruzar lo que hemos comentado, ¿no? El caso que Nacho ha presentado, pues por lo menos permitió avanzar el micro lo suficiente como para poder avanzar la guía de rota. Muchas veces no podemos avanzar la guía de rotablación porque el micro se nos queda muy proximal, pero sí hemos pasado una guía de oclusión. En este caso, yo creo que para lesiones no expansibles como esta, esto fue un caso que hicimos, que Luis Teruel hizo con nosotros aquí, está una epicárdica que bueno, se navegó hasta la descendente anterior y después avanzamos de forma anterógrada. Al ir de forma anterógrada nos encontramos con que en la parte proximal el balón no dilataba y la intención era hacer un reverse cast en ese punto, pero no había manera de avanzar ningún tipo de balón. Ese era un balón de 1,5. Por lo tanto, pues nos quedamos bloqueados en ese punto, ¿no? Ahí tenéis un IBUS en el cual observáis que íbamos por subintimal, ¿no? En esa parte proximal, pero aún así no decidimos hacer un láser. Y bueno, pues tras hacer el láser, como habéis visto ahí, pues conseguimos hacer un reverse cast, un K-reverse y reconectar, ¿no? Y conectando lo que es la verdadera luz. Y fijaros que en la imagen de arriba a la derecha cómo conseguimos romper el calcio circunferencial después de haber hecho el láser, con este resultado final que tenéis aquí, ¿vale? Y el otro escenario que yo creo que es interesante también, pues es las lesiones no cruzables, ¿no? Este es un caso de un paciente intervenido ya, operado hacía más de 15 años con una safena a la DA que se había cerrado y teníamos esa oclusión de la DA. Navegamos en este caso fue una galla secon inicialmente con una fielder, una galla y con un toothpick espiral, el cual se quedó atrapado, la guía pasada hacia la rama diagonal y realmente pues no éramos capaces de avanzar ese toothpick ni incluso retirarla. Intentamos de alguna manera cruzar cruzar de forma paralela para conseguir mover algo ese dispositivo. Al final lo tuvimos que sacar todo, pero volvimos a entrar de nuevo con otra guía y de nuevo hacia el mismo sitio sin poder avanzar de nuevo el toothpick. Por lo tanto, no tuvimos más remedio que sobre esa guía, esa galla, pues hacer un láser, con un aumento de soporte. Ahí tenéis las primeras, fueron muchas aplicaciones, aquí os pongo prácticamente 2, ya con la segunda fuimos capaces de cruzar y una vez que ya pasamos el láser, pues fuimos capaces de meter el microcatéter, intercambiar una guía y tratar la lesión. Yo creo que aquí nos puede aportar bastantes cosas. En definitiva, bueno, yo creo que el conocimiento del material es esencial para usarlo adecuadamente, que debemos tomarnos todo el tiempo necesario para estudiar los casos previamente, para tener un éxito en las posiciones que estamos haciendo, que eso es algo que también hemos comentado previamente, casos de los más complejos en pacientes que habitualmente están estables, ¿no?
Sí,
y ser pacientes y intentar pues hacerlo de forma muy segura y eficaz.
Vale, pues nada, entonces vamos a Puerta de Hierro y que nos cuenten cómo están. Gracias, Antonio. Muchas gracias.
Sí, perdonad que os hayamos metido un poco de prisa, pero el paciente se tiene que ir a la coronaria porque ha estado durante unos momentos bastante inestable y no queremos tenerlo aquí esperando. Entonces, por eso os habíamos metido un poquito de prisa. A Javier ahora os va a contar cómo hemos terminado y bueno, pues, cuando quieras.
¿Podemos ver ¿podemos ver la copia o no?
Sí, Javier, si puedes resumirlo en inglés, porfa, también para todos los...
Hello, sorry for the interruption. We have finished. The patient has unfortunately been unstable during several minutes, and we had to even do cardiac massage because he developed asystolia. That was when we were working through the right coronary artery. And fortunately, he has recovered. We had to intubate him, and we finished. And this is, I don't know if you can see the final result.
Yep. Yeah, we can see
So
it.
at the end, we didn't introduce the Suzuki. We didn't have time to, but we did provisional stenting with several long stents. 4 stents basically, and this is the final result. So even the PDA is open, and the left coronary artery, we have looked at it immediately before taking it out, and it was perfect. So now he has 2 competing sources of blood going to the distal right coronary artery. I don't know if...
As you can see, we had to use the Godzilla 7 friends to deliver the stents, because in the mid right coronary artery it was very calcified. It was very difficult to advance even balloons, even little balloons. So we had to use the Godzilla, but fortunately we could advance
the question was that every time we inflated a balloon, the patient collapsed, absolutely, and after several balloon inflations, we had to do CPR on him and intubate him and stabilize him. And thank you for our colleagues in the coronary unit, and thanks to everybody. Olga, Pilar, our nurses, José Antonio and everybody, Maria del Trigo, they've all been helping to finish this patient. The patient is perfectly stable. I don't know if you can see the blood pressure. This is the femoral blood pressure. And we are going to leave one of the 2 introducers that we changed for a short one. And we took also a central venous line that we will leave in place. We hope it will be left in place only until tomorrow. So I don't know if you have any questions. There were many things going on, many problems. But basically the message we want to deliver to everybody is this is a very delicate patient, very complex patient. You have to be sure. You have to be sure that the patient have at least to discuss at length the possibilities, the pros and cons. You have to put yourself limits to the angioplasty, even though in this case everything went well until we started to work in the right coronary artery. There's very, very delicate patients, not for initial cases, and you have to discuss the indication very, very, very well. That's the take-home message I would like to leave for everybody and for ourselves also. I don't know if you have any questions.
I think, Javier, that you all perform a really good job. The result is fantastic from my point of view. And the most important thing is that the patient is okay. We'll have
the patient is okay. He is 100% saturation, blood pressure is stable, heart rhythm is stable. Oh, no.
Yeah. That is the most important thing. And with the artery open, which is the target that we have to follow.
Okay, so it's time to say goodbye, everybody. Thank you very much for your help. José Ramón, you did a great job. The other panelists also, and it's been a pleasure to have this meeting with you. I hope we can see in other meetings, and thank you very much to the people that has been watching the meeting through internet. Thank you.
Thank you, José Antonio. Nacho, do you want to say anything?
Yes. First thing, I want to say thank you, gracias, Dr. Rumoroso. Thank you very much. I know that this was crazy. Probably you are more tired than after doing a CTO, but coordinating all this is really a mess. And we have had 2 cases very, very complex. So
yeah, very complex.
Moving from one side to the other to the top.
Vamos a organizar el traslado.
So, but I'm very
vamos a organizar el traslado del paciente ya. Voy a poner unos.
Thank you very much to our Portuguese colleagues, Joao, Dr. Cardoso. It has been really a pleasure. I hope next session we can do it in Portugal, so you can start selecting really challenging cases as the ones that we had. Thank you also to Antonio and Bernat. Muchísimas gracias. Realmente vuestra participación ha sido excepcional y bueno, queremos seguir haciendo estas cositas y seguir dando guerra. We want to be there, we want to show how we work, and we want to collect this data to show that we are doing things right, or at least to improve the things that we are not doing right. So this is the final goodbye. I hope we see soon personally. Thank you very much to everybody. Thank you to the participants. Goodbye.
Thank you.
Bye-bye.
Bye.
Bye.